milhares de anos em evolução. E o ser humano em todos os cantos do planeta encontra no sorriso uma maneira de abrir oportunidades, criar laços, expressar emoções. E você é parte essencial na transformação de cada um desses sorrisos. Vivemos dentro de uma constante busca de equilíbrio entre arte e tecnologia, entre a ciência na saúde e a mais pura emoção do encontro entre pessoas que expressam, sem limitações ou receios, suas maiores alegrias. E nesse momento, onde incríveis soluções estão ao seu alcance, a Align está com você, lado a lado numa missão única, que é transformar sorrisos e mudar vidas. Para abrir oportunidades, criar laços, viver cada emoção. E acima de tudo, simplesmente sorrir.
Hello, good morning to everyone, and welcome to the second day of our Align Forum Latam. Dr. Almer, good morning and welcome.
Thanks, Renata. Good morning. Today will be a busy day with lots of information. We'll start with a talk by Dr. Kenji Ojima, and next we'll present a clinical case comparison using ClinCheck. At the end of the day, we have the Align Forum LATAM Awards to crown our event. As Ritesh said in the opening keynote yesterday, the digital revolution and clinical education go hand in hand, and that's the reason why this event exists, to create knowledge for you, our doctors.
And if any of you didn't see something in our presentations yesterday, all the content from Align Forum Latam is available on our platform, so you can watch it anytime you want.
So shall we? Our guest for today's lecture is Dr. Kenji Ojima. He has a degree from Showa University in Tokyo and is president of the Japanese Academy of Orthodontic Aligners. Dr. Ojima has been an Invisalign doctor since 2008 and has treated over 2,500 cases to date with Invisalign. So let's hear what our expert has to say. Please welcome Dr. Kenji Ojima.
Good morning, everyone. Hi, Armir. Muchas gracias. Obrigado. So, I'm Kenji Ojima from Tokyo, Japan. Today, I'm very exciting because share my experience for the aligner orthodontics. So, the specialty to interdisciplinary approaching and the surgery approaching with aligners. I'm very exciting because 2 years ago or 3 years ago, I visited for the Brazil and Sao Paulo. I'm very loved to the Latin America. So I hope the next year I will be there then so that I want to face for the collaboration with the Euros. Today's my topic is very exciting because aligner orthodontic treatment is not only just small tooth movement. This is a very expand for the because interdisciplinary is a prosthetic approaching, some of the time surgery approaching, and the orthodontic treatment is a very exciting field. So this is my office. So I want to go introduce my clinics. This is our office located to the center of the Tokyo. Our two private practice is a specialty to aligner orthodontics treatment since 2007. The one of the office is close to the Shinjuku station. Another office is close to the University of Tokyo. If you have interesting, please visit to our office. So this office is designed to focus on aligners. Then so the big screen is there. Then so our team is introduced for the patient using for the ClinCheck and using for the photos and some of the time digital smart design. Then so the patient is very comfortable because this is no sound and no using the wires. Only specialty to short time, limitation time, after orthodontic surgeries. Many of the patients come to this office, then so they're using aligners. Why aligner is wanted to the patient? One is comfortable, second one is very clean to the oral hygiene, and the three is very exciting tooth movement. This is an emotion. The patient want to emotional change after orthodontic treatment. The patient don't want only tooth movement. Patient want to change the smiling, the face, and the patient life. This location is a welcome to the patient to change your life. Okay. Then so this is another thing, our education center, because this time is very sad time because very difficult to move anywhere. Then so this is our digital aligner orthodontics education center in Tokyo. This education center is very close to my office. Then so that our team is every day, every night is post for the new, I would say, lesson and a new practice education session. So many of the doctors, not only Japan, so the internationally, so the colleagues is attending to like this online education. Then so that we must don't stop the education. Education is very important thing because the patient is waiting to your treatment skill. We have to training to more brush up orthodontics works. The many of the patient is think about aligner orthodontics is very simple case only. How do you think? But now many of the doctors, many of the conference is talking about possibility for the aligner orthodontic possibilities. This is our education center. One is Shinjuku area, another thing is Hongo area. After COVID virus 19 is please visit to our education center. And I want to introduce this website. The website is very exciting. This is Global Invisalign Gallery website. Easy to find my case. Sorry, this is a language, Japanese language. So you can searching the countries, you can select Japan, and many of the Japanese doctor cases post here was very easy to find my case because my case is everything difficult. Category is 3. You have to check category 3, easy to find my case. Initial photos and x-rays, clean check, then the treatment procedures, the final photo is there. Anytime, anywhere, you can easy to checking my approaching. Now, so my case is post to Global Invisalign website around 20 cases. If you have a chance, if you have interesting, please check this website. You can easy to education, you can easy to find my case, and still continue education. That is very important thing. So that I am very excited in this website because many of the countries' doctors post to this website. Around these 20 cases, Invisalign approaches cases, you can easy to find it. This is my team doctors. All the time, thanks a lot for the wonderful works. So our team is orthodontist and oral surgeon, periodontist, prosthodontist. Our team treated to the good work for the patient. Today I want to share with you this book. This book is published on Quintessence Publishers since 2015. This is my mentor, Dr. Werner Schub from Germany. I learned from him. So our team published on this book. If you have an interesting, please read this book. According to this book, Dr. Werner Schub say, very important thing is this. Initially, we have to check the functional analysis first. not only teeth, not only aesthetic only, because the patient is human being. Human beings have to need eating time, talking time, and relaxation time. Many of the time using this jaw, right? Patient, if you have a problem, some pain, that is not comfortable, right? We have to check functional analysis first. If patient have any problem, we have to treat functional problem first. After pain-free position, we started to aesthetic analysis, then we started to Invisalign treatment. After Invisalign treatment, if patient needed, we started to interdisciplinary approaching. If needed, set to the crown, place on the implant, then all treatment is finished, right? This is our clinical works. This is a chart from my clinic. The patient come to my office. The first appointment, we take a documentation. The photos, the movies, the CTs, scanning procedures, then we get the data and we have to check everything, muscle, the joint, everything. Then we get the data, then started to the thinking of the planning. Patient come again, second appointment. At this time, I will introduce what is you needed. Our team divide big 4 group. Group 1 is centric occlusion, or under centric relation, CR, not equal patient. Some of the time, this group patient have a pain. At this time, we are collaboration with manual therapist. After pain-free, started to Invisalign treatment. At this time, some of the time, we use the splint. Second group is started to Invisalign orthodontic treatment. Third group, orthognathic surgery. So my team is focused on surgery first approaching. Some of the time we use multi-bracket system. Limitation, just short time. At this time, we collaborate. As you know, this is a very famous in the world, Dr. Professor Junji Sugawara. The Junji Sugawara and I is a collaboration from since 2013. Then we started treatment 2014. Initially, this approach is very important thing. Patients have the dent facial problems, the skeletal problem patient. OGS, then orthodontic treatment. Group 4 is pediatric orthodontics. Pediatric is a young generation, the kids, the teenagers, okay? So our team is divided 1, 2, 3, 4, big 4 group. Then so every group going to second group, then treated to Invisalign orthodontic approaching. Of course, if needed before going to orthodontic treatment, some of the time end treatment, perio treatment, and the caries treatment, provisional restoration at this time, I send to my interdisciplinary doctors. After end of the treatment, come back again my office, then started to Invisalign treatment. Some of the time Invisalign only, some of the time collaboration with TAT, some of the time some actuaries, then started. End of the also, if patient needed interdisciplinary approaching, I send to the doctors, place on the implant, place on the crown, then after that come back to my office, then started to retention. Then our team normally maintain 5-year follow-up. This is normal our team chart. Today I want to share with you is Invisalign, the surgery approaching and the interdisciplinary approaching. Many of the patients, many of the doctors think about this question. So aligner case, is it only simple case only or not? Let's see these cases. Number 1, number 2, number 3, number 4, number 5, number 6. These cases which treated aligner orthodontics, Invisalign treatment, which number of the case is treated for the braces or lingual braces. So this case, all this case is treated to Invisalign system only. Invisalign system is not only simple case, not only anterior crowding. The vertical control, expansion, molar distalization, and the non-active perio case, every kind of the approaching is possible nowadays. Nowadays, we are possibility to treat for the Invisalign system, open bite, lower molar distalization, upper molar distalization, expansion the arch and the crowding, the deep bite, interdisciplinary approaching, camouflage approaching, and orthognathic surgery cases. Now we all of the cases treated for the Invisalign approaching, right? Today I want to share with you is a very exciting cases. Have a look. This is an open bite and the upper molar distalization and a narrow arch patient, and some of the time lower molar distalization. This is a very, very complex cases. But we treat it for the aligners. We treat it for the Invisalign system. Invisalign system is nowadays is many of the doctors, many of the patients already know what is this, right? What is this is very have possibilities. Now I will show you one of the case. This case is camouflage approaching for the aligners. You can see here is very complex cases because open bite, only contact is molar area. This is a very severe case. How do you think like this patient come to your clinic? You treat it to aligners, you treat it for the orthognathic surgery, and you treat it for the multiple bracket. How do you think? Have a look, our approaching. This is the initial and this is the final. Invisalign possibility is nowadays more and more expansion. This is a comparison initial and the final. This is a totally different before and after. I will show you more detailing. This patient come to my office, 18 years old male. The chief complaint is open bite, anterior cannot bite, and crowding and class 3. Problem is this, how to control molar intrusion. Patient come to my office initially like this. Only contact is right side is second molars, left side is second molar. Only this. Another tooth cannot touch anymore. The patient is very difficult to eating because I only contact second molars. Some of the time just little bit pain and around here and just little pain and the jaw area and just a little bit all the time is tired. Then the patient come to my office. But this patient, one thing, don't want surgery approaching. This patient want to camouflage approaching. Patient is treated to anterior open bite, but this is definitely surgery cases. But the surgery case, but the patient don't want. Some of the time we have to think about plan B. This is initially have wisdom tooth, upper right, upper left, and lower right, lower left. So my planning is this extraction, all wisdom tooth, based on the mini screw, intrusion the lower molars, distalization the molars. Before going to the clinical photos, I will share with you the clean check. This is my clean check. As you can see, lower molar intrusion and distalization lower molars. After that, sequentially distalization premolars, then canine retraction, finally anterior retraction. All of the time, we have to do intrusion in the lower molars. That is the key of the success. Then at this time, I use mini screws. Place on the mini screws is very easy to control molar intrusion because of very strongly anchorage. This is started to the clinical works. Initially, place on the attachment, initially expansion upper and lower arch alignment and the leveling, then started to the intrusion. Molar intrusion is very effectively using aligners because the aligner appliance using patient bite force. That is amazing. If using another appliance, lingual braces, labial braces, cannot use the bite force. But the aligner is covered occlusal aspect, then aligner is easy to use the patient bite force. We have to use the bite force and using skeletal anchorage, mini screw, then distalization lower molars, intrusion the lower molars. As you can see, this patient going to the touch anterior teeth. This is a skeletal anchorage. This is a very, very effectively, right? As you can see, molar distalization sequentially, and you can see the space between second premolar and the first molars. Aligners is very effective control lower molar distalize. If using the TAT, more effective. Going to more distalize, then using some up and down elastic, still using to the elastic from the TAT. Almost is a contact here. Then so there almost is a for the canine premolars. This is a final situation for this patient. You can see second molar, first molar, premolars, canine, anterior teeth, all the teeth contact and good for the balance, and the patient can't eat everything after Invisalign treatment using skeletal anchorage. This is a final situation for this patient. It's good for the occlusion, good for the balance. As you can see, here is a final situation, panoramic X-ray and a cephalo X-ray. So this is final situation. But this patient is camouflage. The skeletal problem is remained. But the patient don't do surgery approaching. This is a comparison initial and final. This is amazing, right? Only plastic, but the plastic is not only plastic. Inside technologies, inside intelligence. So we have to use intelligence and technology using the aligners. This is a comparison initial and final. We can control curve of speed, intrusion the molars, alignment all of the teeth, the wear, alignment, very detailing tooth movement. That is amazing. Comparison initial and final cephalometrics X-ray, totally different is control the lower mandible. Lower mandible is we achieved counterclockwise rotation, then patient more easy to bite it, then finish. This is a final situation, but remains still skeletal problem. Aligner orthodontics is very effective, very effective. Many of the approaching we can do aligner onlys. But some of the time, out of the range, at this time how we can do. At this time, it's better approaching is orthognathic surgery. Please have a look this journal. 2009 Journal of Clinical Orthodontics. The Dr. Hiroshi Nagasaka and Dr. Junji Sugawara and Ravi Nanda and Hiroshi Kawamura, this team published on the JCO article, Surgery First Skeletal Class 3 Correction using Skeletal Anchorage System. This is the first ever in the world Surgery First article.
10 years
That is
have
amazing.
passed since Surgery First was
This
introduced
is
to the world.
2009.
Doctors from all
started
corners
to
of the
the
globe
surgery
have
first
contributed their
approaching.
expertise
Then
to
the
the
many
history
of
of
the
Surgery First
articles published
by pushing the
Dr.
limits of
Professor
treatment
Junji
possibility.
Sugawara. He
The
is the
biggest
top
appeal
of
of
the
Surgery
very
First for patients in
famous
need of surgical orthodontics
orthodontic
is the ability
surgery
to sustain
approaching
a high
using
QOL throughout the duration of
orthodontic
treatment.
treatment. He already 90 times lecture in AAO, American Association of Orthodontics. So that I very impressive his approaching. Then so the collaboration
In August of
aligner with
2018,
Surgery
legendary
First.
Surgery
Since
First practitioners from around the world
2014.
will gather in Japan for the first
Many
ever
of the
summit of this
doctors
kind.
very exciting
This
this
summit will
approach.
bring together highly
Nowadays,
experienced
surgery
orthodontists
first
and oral
approach
surgeons
is
to be the
more
catalyst for the
expand.
start of a new age in orthodontics.
Not only Japan, many of the
Surgery
all over the
First will be a
countries
breakthrough for the
using
treatments of
surgery
tomorrow.
first approaching.
August 26th and 10 years.
This is our team, including the Professor Junji Sugawara and maxillofacial surgeon. Then we treated for the OGS. Traditional one is OGS is a pre-orthodontic treatment. After that, OGS. Then post-treatment. What is the problem this approaching? The one is long-time treatment. Second one, pre-treatment time is very not good the aesthetic because the patient like this, right? But what is benefit for the surgery first approaching? Surgery first, as you know, initially we do OGS, orthognathic surgery. The patient's chief complaint is immediately after OGS correct. Then after OGS, patient the blood supply is very high. This is a lap phenomenon. At this time, the tooth is easy to control, very fast mobility. Then so the short time treatment is a second benefit. Orthognathic surgery, after that, easy to control tooth movement. Then we can do short time treatment. Short time is a more benefit for the patient, right? The patient, every patient wants to very faster and comfortable approaching and the safety approaching. Today I want to share with you surgery first and the surgery early surgery approaching. This is planning. Planning is Junji Sugawara and me. Then after that, maxillofacial surgeon is orthognathic surgery. After that, using skeletal anchorage system. This is a mini plate. Then some of the time using short time period multi-bracket system. It depends on the case. Then remove all multi-bracket system, scanning procedure, then started to the aligners, then finish. This is our team mainly approaching. Many of the doctors, very exciting, very interesting approaching aligners, same as yours. So what is possibility, collaboration, aligner with orthognathic surgery? Okay. Today I want to share with you what is the benefit, what is the possibilities. The surgery first skeletal class 3 correction using the skeletal anchorage system is more and more safety to your treatment. Okay? Skeletal plate, multi-bracket system, it's some of the time after that using aligners. This is planning. Some of the time, class 3, dental compensation, like this, right? Then, so the Junji Sugawara planning, what is benefit? Initially, the setback is a lower mandible. Then, after that, the two contact, second molar, first molars. Then, patient will be like this. Immediate after OGS, setback for the mandible, then two contact. Two contact is this. Then we have to do intrusion the mandible,もしくは intrusion molars, then counterclockwise rotation mandible. That is very important thing, this surgery first approaching. Immediately after OGS, at this time we use a splint because the splint is stabilized to the patient mandible. Immediately after here is a contact, only contact second molars. Then using the splint, then using the elastic to keep this position. Then started to intrusion patient molars, then counterclockwise rotation of the mandible, then alignment. This is a normal protocol Senzai surgery first approaching. Okay? Now I will show you. This is immediately after OGS. Then using the skeletal anchorage system, place on the here, then molar intrusion, like this, alignment. At this time, I definitely recommendation skeletal anchorage system. This is a bone plate, mini plate. This is a very strongly anchorage. Some of the time, molar distalization, some of the time, molar intrusion, some of the time, molar mesial movement. Every single tooth movement possible using from this skeletal plate. Intrusion, distalization, mesialization, everything. The surgery first approaching is we three big doctors, maxillofacial surgeon, and Junji Sugawara, and me. This is the finally is aligners. We have many of the case for the treated for the OGS surgery first approaching. This is the initial. Immediately after OGS, using the splint. After surgery first. If patient needed short time, limited multi-bracket system, it depends on the patient's situation. 1 month, nothing, 3 months, 6 months. Then shift to the aligners. Finishing the aligners. This is the final situation. Okay? This is a protocol, normal protocol our team approaching. Okay, today I will show you our team surgery first cases. The case 1 is very simple one. I will show you skeletal anchorage system, short time multi-bracket system, then after shift to the aligners. Features of our surgery first is our surgery first method is an ortho-driven approaching, unlike some other surgery first approaches. Number 2, our surgery first is applicable to the more than 90% of jaw deformities. Number 3, with the application of SAS, skeletal anchorage system, the orthodontist can carry out post-surgery orthodontic treatment more predictably and securely over a short period of the time. Feature of our surgery first. Number 4, our surgery first can significantly reduce the extent of surgery intervention. Number 5, in our surgery first, the responsibility of the orthodontist is heavier than that of the maxillofacial surgeon. Number 6, the long-term dentofacial stability following our surgery first was acceptable. Okay, I will show you new approaching surgery first in combination with aligners. Oral surgeon and Junji Sugawara, finally aligners. So our team and Junji's team is collaboration. Then we started to the new approaching surgery first with skeletal anchorage system, aligner with acceleration. This one already you know. What is benefit for the surgery first approaching? We can use lap phenomenon and sap phenomenon, easy to control, and the molars and tooth movement is very faster. That is amazing. Our team published on the Journal of Aligner Orthodontic 2018. This is the first ever Invisalign aligner using surgery first cases. If you have an interesting, please read it. Okay, I will show you initial case. This case, skeletal class 2. This patient come to my office initially. The chief complaint is severe overjet. This patient already extracted upper 1/4, upper 2/4. Because this patient already received orthodontic treatment since junior high school days. 26 years old female patient come to my office. This is situation. As you can see, upper first premolar is already extracted, and lower side, upper side, including wisdom tooth. This is a facial photos. The patient chief complaint is a severe overjet and don't like for the smiling. What is problem for this patient? We have to check precisely. This is a patient smiling. The patient is talking about us. This is a very severe overjet and not good smiling. Then Dr. Junji Sugawara and I started to the planning, started to the checking everything. What is problem for this patient? This patient problem is this. The short mandible. This patient is very short mandible. Then we have to do surgery first. We can do surgery first, as you know. But if this patient mandible is a small size, if mandible advancement at this time will be patient is class 3, because that patient already extracted upper first premolars. Lower side is remain all the teeth. If immediately after OGS, patient will be class 3 like this, not good aesthetic, then Dr. Junji Sugawara and I planning. Before OGS, we use Invisalign treatment first. Have a look. Pre-surgical phase, extraction, additional lower first premolars, 34 and 44. Extraction. Then scanning procedures, started Invisalign orthodontic treatment, pre-surgical approaching. Going to retraction, lower anterior teeth and canine. Lower anterior retraction and canine retraction. Short time limitation. After that, lower anterior teeth is a setback. Then OGS, orthognathic surgery, mandibular advancement. Like this, advancement. Because the patient already retraction lower anterior teeth, after OGS, not situation class 3, close bite. This is a good for the aesthetic after OGS. After OGS, this patient have a 2 months. Patient is very free of the works, free of the schedule. Then we use limitation, short time multi-bracket system because this time lap phenomenon. After 2 months, remove all the braces, then started to Invisalign treatment. This is our approaching, planning. This is our team planning. Pre-surgical phase, extraction lower first premolars, started to Invisalign treatment, lower anterior teeth, retraction. After that, mandibular advancement, OGS, orthognathic surgery, then limitation, multi-bracket system. After that, remove all the braces, then scanning again, then started to the Invisalign treatment, then final. Okay, this is our team planning. This is post-extraction. Please check the date. November 2017. The patient started to place on the skeletal anchorage, as you can see, and post-extraction 34 and 44. This is a clean check. Have a look. This is a very simple. Upper teeth is alignment. Lower teeth is retraction. Canine retraction and the lower anterior retraction. Then after that is including set mandibular advancement after retraction. The clean check system is including surgical planning. That is amazing. After retraction is advancement for the mandible. This is our team planning. Nowadays, normally our team is like this situation, place on the attachment, canine, premolars, and the first molars. That is very effective. Some of the time we use vertical rectangular attachment. That is amazing. Okay, this is a clean check. Attachment on, then started to the aligner orthodontic treatment after 1 month later. And we use acceleration device, orthopulse device. Aligner change is 3 days. 3 days aligner change. This is end of the first phase. End of the first phase is this patient is a 4 months treatment, 4 months after. As you can see, the space is closed and more severe overjet. This is a good. This is a planned. This is planning also surgery using dolphin surgeries. This is our team is planning mandibular advancement like this. This patient is our team planning is one jaw surgery. Lower mandible is BSSO. We do like this. Advancement is a mandible, then finally is a good position and the mandible. We have to check which position is good for this patient. The patient is good for this position, then we are planning and we are discussing maxillofacial surgeon. Pre-surgical approaching, we remove all attachment and put on this button, only this. Very, very simple. Normally, orthognathic surgery patient is put on a lot of the braces, right? But Invisalign system, OGS, is very simple, like this. 6 months after tooth movement started to OGS. After the post-surgery, using splint, already you know why we use splint. Some of the time, molar is contact. Then this is post-surgery. 6 months later, the patient using elastic up and down, only this, very comfortable. And the patient in the brushing time and the eating time, remove the elastic, remove the splint, and eating is possible. After eating, after brushing, toothbrushing, is a insert splint again, and using elastic again, only this. That is amazing. If traditional multi-bracket system, traditional OGS is very tough because the fix up and lower all the teeth, cannot open, cannot brushing. This is the post-surgery, this patient. As you can see, mandible is advancement. Using splint insert here. Now this patient is 6 months later after tooth movement. This is 6 months later post-surgery. Is a bone plate here, 2 bone plates this side, and 4 point is insert skeletal anchorage, mini plate. That is very important thing for our team. Then, short time multi-bracket system. 8 months after, our team place on the braces, because at this time is using LAP phenomenon. Regional accelerate phenomenon. After OGS, the blood supply is very high, then so the easy to control patient tooth. Then so the patient is off of the schedule at this time. Then planning. Then we do place on the multi-bracket system. Alignment. After 2 months later, is a molar intrusion and remove the splint like this. Just 2 months. That is amazing, right? Because we use LAP phenomenon, regional acceleration phenomenon. Then, 8 months after, remove all braces, then scanning plus procedures. Patient is very comfortable because all remove the bonding, just 2 months, right? Then this is a second clean check. Second clean check is very simple. Have a look. Alignment midline and the space closing and the control for the vertical support. Midlines correct, alignment. That is very simple, right? Dental facial problem patient after OGS, tooth movement is very short. If camouflage patient, tooth movement is very big. But OGS, after OGS patient, tooth movement is very short, little bit, because already the big shape, big change for the mandible, big change in the maxilla, then so the tooth movement is very short, very, very simple. Started to second phase. Of course, this patient, 3 days aligner change, 9 months after. And as you can see, elastic using aligner precision cut and put on the canine, upper right, upper left, and lower right, lower left. Easy to control midline shift. This is the skeletal plate. Mini plate is a sanction rod for the skeletal anchorage. Easy to control facial midline correct. If patient mandible shift to the left, or shift to the left, right, using elastic, then easy to control midline correct. If without skeletal anchorage, that is very difficult. I definitely recommendation if using orthodontic surgery case plate on the mini plate, that is more safety. This is 11 months later, patient is tooth movement is finished. Midline is correct, the canine and the molar is a class 1 relationship achieved. Then so the overjet and the overbite is the functional ideal position is achieved. The patient is good for the position all over the tooth. This is after orthodontic treatment. Here's end of the treatment. The smiling is good. The aesthetic is good. The patient is very comfortable and very easy to smiling. As you can see, dramatically change, not only teeth change. If collaboration, orthodontic surgery is you can change the patient dentofacial problem. This is a comparison initial and final. That is totally different. Initial is a very small mandible. The final is an ideal position achieved. This is smiling for the profile. That is very aesthetic because the patient is a problem is a small mandible, right? This is another angle. Is initial one. The patient thinking about themselves. Problem is upper teeth, but we have to searching what is real problems. Real problem is skeletal problems, the short mandible. If you is change different planning, if extraction more upper teeth retraction is not good for the result because we have to check what is real problems. This is initial and final, totally different. This case is surgery early with aligners, not surgery fast. Surgery early because initially is Invisalign approaching, then OGS realigner treatment. This is a comparison initial and final, totally different. The patient is dramatically changed, not only teeth, is dent, facial, everything. This is 2 years retention for this patient. Is a midlines correct, and the canine and molars is good for the position, the stable, 2 years retention. This is a 2 years retention. Is a dramatically change the teeth, the smiling face, and the hair. This is a dentofacial changes, initial and immediately after OGS, and debonding started to the aligners, end of the aligner treatment. Total treatment time is this. 4 months before orthodontic surgery. The 2 months after OGS, 2 months is a short time for the multi-bracket time. Then after that, aligner orthodontic again. The total treatment time is 11 months, then finish. The less than 1 year. That is amazing, right? This is the dentofacial changes. This is the initial situation. This is the immediately after OGS, end of the ortho. This is finally 2 years retention. So that this is a possibility to the aligners. Aligner orthodontic treatment is not only small teeth movement and only easy case. Have a look. Totally different. We can do like this complex case patient on the table. After 2 years of retention, the smiling is good, occlusion is good, patient is very happy. The summary of this patient. Aligners, the before OGS 4 months, then OGS, the BSSO, the one-jaw surgery, using the splint, because the splint is very important thing, because the patient after OGS is not stable. Patient don't understood which position is good or not. At this time, the splint is easy to support right position or comfortable position. Then, so the use skeletal anchorage system, mini plate, using 4 mini plate, then limitation, the short time, multi-bracket system, 2 months, then after that, retreatment aligners, 5 months. Total treatment time is 11 months for this patient. The next case is skeletal class 3 digital smile design. Initially, patient come to my office. This patient just a little bit mandible shift to the left, right? Then, so the 2017 May, the patient come to my office. Of course, this patient too, the Dr. Junji Sugawara and I, our team, is treated for this patient. We have to check precisely everything. The patient is a beautiful result. Yes, we want to do. Have a look. This patient already extracted, same as last patient, upper right first premolars. Since junior high school days, this patient already extracted upper left first premolars. Upper left first premolars. 24 is already extracted. Then anterior crossbite, midline is deviation, is not good for the occlusion, and the upper right is high canine, is not good for the smiling. The patient is want to change the beautiful smile and good for the occlusion. What we do, this is initial planning for the Junji Sugawara. Then, so initially we have to check the planning for the OGS using dolphin surgery. This patient is initially we do surgery first. How millimeter is control is we can easy to check using these technologies. The computer simulation easy to understood is how millimeter control is good for this patient, right? Mandibular, this patient is setback, and we planning the one jaw surgery, the BSSO, and this is create for the sprint after OGS. Everything is simulation, computer made. This is planning for this patient. Is we understood how millimeter is setback, is a jaw shift. Then going to start it for this patient. Initially, this patient midline is big deviation, mandibular shift to the left. Then started to the pre-orthognathic surgery. Put on this, only clip here. Right side, 4 clip, left side, 4 clip, only this. Very simple. Then this is a post-operation using splint. Because already you know, it's a post-orthognathic surgery, patient cannot understand what is good occlusion stabilization. They don't understood which position is good or not. Then the splint is is good, guided for the stabilized occlusion position. Then our team thinking about, this is a post OGS, just a little bit here is color change. Then we started to the sprint control adjustment. 2 weeks after OGS, patient is still good. Then as you can see, already you know, is a lower midline is correct. After OGS, the patient mandible is midline is correct. Then so our team is planning, have a look. Extraction upper right first premolars, because the left first premolar is already extracted. Okay? Then upper right first premolars extraction, then place on the short sectional arch wires, then control. 3 weeks after OGS, then 4 weeks after OGS, all remove clip and all remove sectional wire, then scanning procedures started to Invisalign system. After OGS, started to precise face. This is the initial clean check, very simple. Canine retraction, right? And control the bite. This is the initial. After OGS, very simple. 2 months after post-operation, post-OGS, as you know, already we use lap phenomenon. After OGS, blood supply is very high, then we don't use any acceleration device, but the aligner change 3 days. That is amazing. 3 days aligner change, but the patient don't very tough, don't pain, easy to insert, very comfortable, then 3 days aligner change. At this time, we use skeletal anchorage, easy to control canine retraction and any tooth movement. 3 months later, still continue 3 days aligner change. Don't use any acceleration device because they're using lap phenomenon. Aligner fitting is amazing. Aligner fitting is good. Then we still continue using. But we started to use also pulse device. Why? After OGS 3.5 months, the patient told me just a little bit tough. 3 days aligner change without any acceleration device. Okay. My idea is this. After 3 months later, lap phenomenon is decreased. At this time, we have to use the human technologies. Then we use also pulse device, then still continue 3 days aligner change. 3.5 months aligner fit is good. This is my image. After OGS, lap phenomenon, blood supply is very high. But 3 months later, lap phenomenon is decreased. Then we use technologies, photobiomodulation. Then still same 3 days aligner change. This is the 5 months after operation. This is 6 months later after OGS. Tooth movement is finished. Tooth movement is finished, midline is correct, canine guidance is good, and the all space is finished. End of the treatment for the orthodontic treatment. This is comparison initial and after. The patient is very beautiful. Not only teeth, smiling, the face, everything. The patient has told me very faster treatment. That is amazing. If you possible, more beautiful approaching. Okay, if you want. Then we collaboration, digital smile design. So the Christian Coachman team and me is using digital smile design. Thanks a lot, Christian Coachman. Thanks a lot, DSD team. Then we are planning that this patient after OGS, after Invisalign treatment, what is more beautiful teeth for this patient. Our planning is this: place on non-preparation veneers. This is our team DSD 3D IDR post-treatment. That is amazing. That is the technologies. Then non-preparation, only scanning procedures. Then this is a mock-up. Then this is a scanning after orthodontic treatment. This is digital smile design, non-preparation veneer. That is amazing. Scanning after orthodontic treatment. We get it from DSD team, this beautiful laminate veneer. This is a non-preparation. That is amazing, right? Very beautiful. Monolithics, the shape, monolithics is colors. Place on the canine to canine. This is the monolithics, so the non-preparation veneer. After 10 months later, orthodontic surgery. This is the place on the veneer here. Thanks a lot for the DSD team. Thanks a lot, Christian Coachman. And thanks a lot for the Align technology. Amazing for the technologies. This is after OGS 10 months later. The patient placed on the veneers. Have a look. This is a comparison 10 months later, just 10 months. Last patient, 11 months, but this patient, 10 months, less than 1 year. Initial and final. That is amazing. The teeth position is changed, and the smiling is changed, and the facial is changed, the teeth color is changed. This is a non-preparation. That is a very gently and safety for the natural teeth. This is a comparison initial and final. Treatment time is just 10 months. Comparison, this is a cephalogram X-rays, totally different. Summary of this patient is a OGS, one jaw surgery, BSSO. The sprint is using sprint for 4 weeks. Skeletal anchorage system, mini plate is a 4 plate. And the limitation multi-bracket is just 1 month, just 4 weeks. Aligners is 5 months. Total treatment time, orthodontic treatment is 6 months. That is amazing, right? That this case is today's last case. Aligner orthodontics with sleep apnea and surgery first approaching. This patient is a long history. Initial orthodontic surgery is 90 years ago. 90 years ago, this patient received initial orthodontic surgery. This is 2001, September, 90 years ago. This patient is a severe crowding and class 3 situation, and the upper right lateral incisor is inside, and the severe clouding. This is a very complex cases. Then this is a facial. This is an initial situation, not my clinic, another hospital. This is a CDS analysis that this patient definitely just big is a lower mandible. 90 years ago planning of this patient orthodontic surgery, not my clinic, not my team. Extraction, all fast premolars, 1, 4, 2, 4, 3, 4, 4, 4, extraction. Then pre-surgical orthodontic treatment. then upper anterior teeth retraction, then one jaw surgery, mandibular setback. After that, what's happened for this patient? This patient airway is very, very tight after this treatment. Post-surgery orthodontic treatment, the patient is very tight for the airway. End of the first treatment, 15 years ago. Total treatment time is 4 years because this is a traditional orthodontic surgery approaching. Pre-orthodontic treatment, OGS, post-orthodontic treatment. 4 years for premolar extraction, BSSO, one jaw surgery. After that, patient come to my office. This is the comparison of initial and the final. As you can see, airway is very narrow. Time is after 15 years. Come to my office, the patient. 15 years later, retreatment. Why? The patient is 2019, 3 years ago, December. Patient come to my office. What is this? I asked to him, why your chief complaint? The patient told me, my chief complaint is cannot sleep. Very, very tough time, sleeping time, because the soup stop breath. Cannot for the deeply sleep because the sleep apnea is started. Patient come to my office. This is 1 year ago. The age is 46. We check cephalometrics. You can see very, very narrow airway. Patient every night is very, very tough time because air is not easy to insert his breath. Very difficult. Have a look. This is the sleeping time for this patient. Started to the sleeping time. 15 minutes later, the patient is, the breath is stop. 30 seconds. 30 seconds is the breath is stop. After that, that is very, very tough every night. This is not only one time. This is a stop the breath. That is a very dangerous situation. This is what is the problem is a sleep apnea. Some of the time is life is dangerous. Stop the breath. As you can see here, that is very, very dangerous. This is every night, not only one time, every hours. Then, so this is examination. Apnea hypopnea index AHI, 48.4. This is time per hours. That is a very severe score because over 30s, AHI is severe. So moderate is 50 to 30s. The mild AHI is 5 to 15. This patient 48.4 score. This is a very, very severe. After over AHI score high, we have to need subjective symptoms. Yes, CPAP therapy or intraoral appliance. We have to need advanced mandible, then we have to need wide to the airway. That is very important thing. But some of the time, patient difficult to use because sleeping time, patient cannot use this one. Or every day, every night, every day, every night. That is very difficult to using for the patient. At this time, abnormal facial morphologies. What is good approaching is mandibular maxillary advancement. That is MMA is one of the good solution for sleep apnea patients. This is our team planning of MMA, mandibular maxillary advancement. Using skeletal plate here, then two-jaw surgery, lower mandible and upper maxillaries is advancement. This is our team planning. Initially, patient is airway is very narrow. The difficult to the sleeping time is breath. Then so our team is using OGS, then maxillaries and mandible, the both is advanced. Then we can create for the airway space more advanced. Then the patient after MMA is easy to breathe at sleeping time. That is a benefit for the patient, the life, not only sleeping time, is a safe of his life. That is very important thing. Our main target is this. We want to create airways. Then so the planning. What is planning? So we are thinking about not only teeth. Teeth and the integration is the root, integration the gum, integration the bone, integration the face, everything. Because we want to do is most ideal treatment planning. Because this patient already retreatment, OGS. What is good? What is ideal treatment? Not only teeth, not only face, including airways. Then our team is advancement, MMA, maxillaries. This is the LUFO approaching. This is the BSSO. Then advancement. Then create for the space for the airways. This is our team planning, simulation for the dolphin surgeries, like this. After this planning, will be more expand this patient airway, easy to breathing every night. This is a planning like this. Not only one jaw surgery, is both of sides is more effective, is good for the sleeping time. This is planning here. So nowadays is our Invisalign treatment is not only teeth alignment. This is OGS surgery for this patient. So the Dr. Hiroshi Nagasaka, he is a maxillofacial surgeon. Thanks a lot for the wonderful surgery. That is amazing and a beautiful result and very good for the detailing for the bone control and the safety approaching. This is approaching to the mandible for this patient. This is a LUFO1 osteotomy upper side. Then after that is fixation from bone anchors. And as you can see, at the same time is placed on the skeletal mini plate. Okay? This is an interpositional bone grafting. This is ramus osteotomy, BSSO, bilateral sagittal splitting. That is amazing works. It's a very precisely bone control. As you can see, this yellow line is a mandibular advancement area. That is mandibular advancement. Skeletal anchorage system, SAS, is here. We place on the same time. That is very faster, very easy. Then here is a place on the mini screw intermaxillary fixation, IMF, with anchor screw. This is a post OGS after 3 days. Post OGS 2020 April. Post OGS. As you can see, is a comparison before and after OGS. Blue line square is before OGS. Red square line is post OGS. As you can see, totally different airways. Post OGS 3 weeks after for this patient. Three weeks after, take a scanning procedures, started to Invisalign treatment for this patient. Aligner treatment is controlled precisely tooth movement, clear aligner treatment. Good for the control. The post-OGS 2 months. Aligner treatment is finished. Every single aligners, 2 days aligner change because as you know, after OGS we can use lap phenomenon. That is amazing. 2 days aligner change, right? Without any acceleration device. Natural lap phenomenon. This is a comparison initial and fine after OGS cephalometrics. Totally different. Comparison for the airways. Upper side is pre-OGS, very narrow. The lower figure is final. After OGS, you can see airway is expanded. This is evaluation after OGS. As you can see, AHI, apnea-hypopnea index, 7.0 score. The post-OGS 2020 July. Totally different for the score. The before OGS 48.4, after OGS, Invisalign treatment, 7.0 scores. This is after OGS for this patient. Is all the time good sleeping, very comfortable. Don't stop any breathing. All the time is comfortable. That is good for the life for this patient. It's safe and high quality and very safety. Comparison airway total treatment time is 3.8 months. OGS and Invisalign system. After that, this patient want to change more beautiful non-preparation, this is all veneers, non-preparation. The final restoration is here. Full of the mouth, this patient wants to change the beautiful teeth. Thanks a lot, Dr. Masao Yamazaki, the wonderful works. This patient is after OGS and want to change more beautiful teeth. This is end of the works, end of the treatment. He is smiling and beautiful and good for the sleeping time and the safety for his life. The summary of this patient: Tsujo surgery, BSSO, and the LUFO1, using the splint, the 4 weeks. Skeletal anchorage system, SAS, is a 4-plate. Aligner is just 3 months. Total treatment time is just 4 months. This is a systematic review 2015. Efficiency of clear aligner in controlling orthodontic tooth movement. Thanks a lot, Gabriel. Thanks a lot, Tommaso. According to this article, many of the doctors and the researcher is checking for the aligner orthodontic possibilities. This is the conclusion. CAT means clear aligner therapy. CAT is an effective procedure that is able to align the leveled arch in non-growing subject. The anterior intrusion movement achievable with CAT is comparable that report for the straight wire techniques. That is amazing. CAT is not effective in controlling anterior extrusion movement. We need attachment. CAT is not effective in controlling rotation, especially of rounded teeth. So we need place on attachment. CAT is effective in controlling upper molar bodily movement when a distalization of 1.5 millimeters has been prescribed. That is a nice score. CAT is not based on the aligner alone. It is required the use of the auxiliaries, attachment, inter-arch, elastic, IPR, alternated aligner, gemo material, and some of the time orthognathic surgery. So we have to think about what is the good approaching. Some of the time aligners, some of the time is combined to orthognathic surgery with aligner orthodontic treatment. So the aligner orthodontic treatment nowadays, that is amazing possibility to OGS patient. So that today's my part 1 is finished. Thanks a lot for the attention.
So that's it. Another excellent talk at the forum. Just to give you one idea, Dr. Ojima has more than 2,500 cases treated using Invisalign. Many smiles. And it's no accident that not only an expert, he's a renowned international speaker. It's an honor for us to have him with us at the Align Forum Latam directly from Japan. Well, now we're going to take a quick break and we will be back with the second part of Dr. Ojima's talk. We'll be back in a minute.
Invisalign, doctor. Do you know the benefits of the Invisalign GH technology in the treatment of your patient's teeth bite? For those who are starting with this type of treatment with Invisalign, you might feel a little lost. What are these names? G8. From time to time, Align Technology, after carrying out a lot of clinical studies, brings a lot of innovations together and launches some sort of package. We had G5, G6, now we have G8 that will tackle two types of malocclusion to simplify our planning process in the clean check. One of these malocclusions are the exaggerated overbites. So I'm going to talk about them now in this video. Let's have a look at this clean check. I'll explain to you what the innovations are. The innovations that we will have are, in the first place, in the calibration of the intrusive force of these lower interior teeth. So when we have an exaggerated overbite, we have to level this curve. So what will the G8 bring us? If you have more than 0.5 millimeter of intrusion of these interior teeth, you will have the possibility of better distributing the calibration of the intrusive force of these teeth. So this already existed, this differential force to carry out this intrusion, because teeth present different needs of intrusion, but this has been enhanced. So we have results that are twice as predictable when we compare to the pre-G8 stage. And there's another innovation of which I am a big fan. And these are things that will be placed automatically if you authorize that in your prescription. The precision bite ramps. If you have intrusion in this lower interior section that is over 1.5 millimeters. So let's have a look what these bite ramps are. These are these ramps in lingual position in the upper incisor that will help in this intrusive movement. Clinical research at Align show that we have a up to 30% improvement when we add the precision bite ramps in the cases of exaggerated overbites. So for this reason, they will come automatically in your first clean check if we have an intrusion bigger than 1.5 millimeter. So I'm going to show you here now so you can visualize our planning in a clear way. So we have this situation of a deep curve of speed. Now I'll click on play and we'll see the correction with intrusion of the incisors and of the canine too. How are we going to visualize that in our clean check? So I'm going to zoom in now. So the teeth that have G8 activation will be hatched in blue, as you can see. So in the chart of movement, you will be able to realize where there is activation. And as I told you, what is the trigger to get better distribution of these intrusion forces? That's when we have more than 0.5 millimeter of intrusion. So look, we have higher levels of intrusion than these 0.5 millimeter ones. And if we observe the bite ramps in the upper arch, they will be placed automatically. So here's my tip for you. I also like to request for the back teeth the placement of optimized attachments of retention or bite, because I need to have an anchorage in the back teeth to support this level of intrusion that I have in this case, that I have planned for this case. I also request optimized attachment of retention or deep bite for these back teeth. Let's compare now what has changed compared to how I used to plan before the existence of the G8 and now. So there are two screens. On the left side, I have a situation where I planned my process before the G8. So what has changed in my way of planning? What has simplified my clean check? It was a level of overcorrection in this curve of speed in the lower arch. Have a look. Before these G8 innovations, I needed to overcorrect a lot more. Now we are reaching the last stage, the last programmed stage. Let's have a look again. Look at the difference that I obtained. I clearly have here a curve of speed, a reversed curve of speed, and now I have a much more subtle curve of speed. Let's have a frontal view now. Look at the level of overcorrection that I needed to program my clean checks. And now with G8, look at how much overcorrection I need now. It's much less. It's much more subtle. And if I need to overcorrect less, there is another advantage because we will need fewer stages to finish the case. So we'll also have quicker treatments. We're going to be more efficient in this intrusion movements. So here is my tip on how G8 has modified my planning in terms of exaggerated overbite.
So now let's see the second part of Dr. Kenji Ojima's talk.
Hello everyone. So okay, let's start again. So my second topics. The second topics is interdisciplinary approaching with aligners. What is interdisciplinary approaching? So my team is a collaboration with Digital Smile Design. Thanks a lot for the Christian Coachman and thanks a lot for DSD team. But there is a very easy to understood for the patient communication is what is the goal after orthodontic treatment for the aligners. In my team is take photos and movies. Then so the create for the planning, what is good for the goal for the patient. Invisalign treatment is alignment of the teeth because the orthodontic treatment is the teeth movement is good. But so if interdisciplinary approaching, we can more expand. What is expansion is change the color for the teeth, change the shape of the teeth for the patient. Everything. If only orthodontic treatment, we can do only tooth position changes. Okay? But if interdisciplinary approaching, we can more expand. Change the shape of the teeth, change the color of the teeth is a more good result. This is a DSD Award 2019. So the last year, I received for the DSD team, thanks a lot, Christian Coachman. I have the most DSD and Invisalign cases of the years. The last year, 2020. So I sent to the 2019 is the most, many of the case, so the collaboration DSD with Invisalign approachings. But what is DSD, what is the visualization? So we all the time check precisely, take photos and the movies and create what is a good goal for the patient. So many of the time we check not only tooth movement. Tooth movement is very, of course, yes, because we are orthodontists, so we have to think about tooth alignment. But after end of the also, what is good more advantage? So now I will show you my interdisciplinary approaching Invisalign with Digital Smile Design, interdisciplinary approaching. The first patient, 35 years old female patient. Patient come to my office, anterior crowding and midline shift deviation. The patient have many problems, not only tooth alignment. Patient want to, after end of the ortho, she want to change upper 1-1 and upper 2-1. Prosthetic is changed because nowadays it's not good crown is insert. Have a look all the photos. So this patient is a chief complaint is anterior crowding, is lower anterior teeth not good, a narrow arch. She want to change the teeth position. Then after that, want to change upper crown. Okay, this patient is not good crown insert for a long time. Then this is facial photos. Then so the patient come to my office. Nowadays, easy to find. Lower anterior teeth is cannot see it. Very deep bite, severe deep bite. If severe deep bite patient is very difficult to insert the good, ideal prosthetic crown. At this time, orthodontic treatment is very important thing. Orthodontic treatment is basic treatment for all dental treatments. The before crown, before implant, before periodontic approaching, the basically tooth alignment is very important thing. not only beautiful, not only smiling. Alignment teeth is basically health of the patient mouth. At this time, we use digital smile design. The face integration clean check, easy to understood final position. What is ideal position? How millimeter intrusion? How millimeter control? What is midline deviation? The canine to canine, which position is good? All answer is this, including the face. If without a face, we never understood which is right position. Yes, of course, if only teeth, nobody understood right position. Of course, patient, of course, all of the dentists, all of the orthodontists. The face integration clean check, that is key of the success and the key of the planning. Have a look. The face integration clean check, including the lip, including the face, we understood this is the right position. This is a beautiful smile. This is good for the smile line and the position and the harmony of the lip. We all the time checking the soft tissues and the muscles and the lip shape and the patient, the face. After the good position, we check more detailing. At this time, we check using the clean check because the clean check is a tool of the tooth movement. The canine control, the molar distalization, and the anterior alignment, how millimeter expansion, we understood nowadays. It's understood because the upper anterior teeth position is already decided from the face. Okay, this is my clean check planning for this patient. Then we understood expansion and intrusion lower anterior teeth. Expansion, create a space, then control axis of the root. Expansion and intrusion. Now you can see is the lower anterior teeth is an intrusion. Arigatou. So expansion, canine to canine, and the lower anterior teeth intrusion, alignment. Now we change provisional restoration, the upper 3 incisors, because it's more easy to control. Please have a look. This is still during orthodontic treatment, but how aesthetic, how beautiful. If normally the patient using orthodontic treatment, all of the teeth put on the braces, maybe. So the many of the adult patient, senior patient, and the specialty aesthetic demand patient don't accept put on the braces. But still, during orthodontic treatment time, how beautiful approaches and easy to brushing, easy to eating, comfortable patient during orthodontic treatment time. As you can see, upper anterior teeth is going to control for the teeth axis, and the lower anterior teeth is intrusion. This is good for the control for this patient. Now you can see lower anterior teeth is good for the intrusion, and canine to canine is good for the position. Then more precisely control upper anterior teeth axis, because this teeth is a non-active teeth. We have to precisely light force. Aligner is definitely most light force and gently control. Now this patient anterior teeth axis is good. Then so that we have to check position. Then this is the final restorative dentistry crown. Upper 1 2 1 1 2 1 2 2. This is finally good for the crown insert, because after we get it for the good anterior guidance, after good canine guidance, we control the vertical control, everything. If before tooth movement, we never place on the ideal anterior crown insert because the very deep bite cannot insert. Nobody cannot do like this. But after control orthodontic treatment, everybody easy to set on the right, like this aesthetic crown. Have a look. So this is with aligners. I definitely recommendation aligner with teeth. The photo is that is very important thing. Why? We check all the time my clinical works, my clinical response. Everybody, please take a photo with aligners. That is very easy to checking my clinical works. My clean check is good reaction or not, easy to understood checking my photos with aligners. Please take a photo with aligner. That is a key of your step up your works. This is end of the ortho. So the canine guidance achieved, class 1 relationship, the molars, midline is correct. We can achieve the good canine guidance. We can achieve anterior guidance. This is the final position in the face photos. That is totally different before and after. We are same as this, the final position, the before planning tooth movement. This is comparison initial and after. That is a totally different. After also, we can do like this. If without any orthodontic treatment, nobody do like this. Only change the anterior crown, but that may be easy to broken, easy to chip the crown, and maybe not get long-term stability. Because if good for the long-term stability anterior crown, that is basically is anterior guidance good, canine guidance is good, good over bite over jet. That is key of the long-term stability. Initially, no did it. So after orthodontic treatment, we can do everything. So orthodontic treatment is a order basically approaching any dental treatment, prosthetic treatment, perio treatment, and caries treatment, everything. Comparison initial and final, that is totally different, very beautiful result. And this is the facially, the tooth size and the position, alignment, everything is different. That is amazing result. This is 2 years retention. That is very important thing. Alignment is very difficult, but the more difficult one is retention phase. Because if end of the ortho, easy to happen, relapse. That is amazing. That is very sad time, right? Because retreatment again, patient have to need a repayment for your clinic. Nobody is unhappy, right? So the very important thing, keep protect the right ideal position for your patient. Okay, that is very important thing. Canine guidance, anterior guidance, that is the key of the success for the retention. Have a look, 2 years retention, tooth is stable, margin is good, occlusion is good, the patient is still happy, and a beautiful smile. The next case is interdisciplinary treatment patient. This patient is come to my office. This patient is our team published on the JCO article with my colleagues. Thanks a lot, Dr. James Lin. Thanks a lot, Eric Liu. Thanks a lot, Jay Beaumont. So our team published on the JCO article at 2017. This article title is Interdisciplinary Aligner Treatment of Short Face Patients. If you have an interesting, please read it. This patient, what is chief complaint? This patient, 27 years old female patient. Patient have any problem? What? Midline and canting and the molars, canine. What is this? This patient, upper right lateral incisor is missing. Then upper canine, upper right canine 1, 3, 2, 2, 2 is fixed. The one bridge, long bridge. Then where is this patient problem is? Problem 1, severe overjet. Severe overjet, not aesthetic teeth. Problem 2, lower anterior teeth clouding. Lower anterior teeth clouding for this patient. Problem 3 is no space insert implant. Very narrow, the space between upper right canine to upper right incisors. 1, 3, 2, 1, 1 is very tight, right? Problem 4 is not aesthetic upper anterior prosthetic crown. Upper anterior crown is not aesthetics. Problem 5, gingival recession. This patient, lower anterior teeth, gingival recession is there. Big 5 problem, patient come to my office. How we can do? Treatment plan is this. Ask to the prosthodontist, how can we do? This is a remove old bridge, then insert new bridge, or some of the time create a space between 1, 3 to 1, 1, then insert implant. At this time we have to need root control. And some of the time we need alignment lower anterior teeth. Very simple idea, extraction lower anterior teeth, 4-1. If 4-1 extraction, how do you think? Easy or not? My idea is this. If extraction lower anterior teeth, we need canine to canine is more tight because one teeth extracted. We need space closing. So the canine to canine, 4-3 to 3-3 is more tight. Then upper 1-3 to 2-3, how do you think? Tight or wide is better result after orthodontic treatment. Now this patient is very big crown insert. At this time, its better result is expansion upper canine to canine, then alignment, then retraction. That is good result. But if you extraction lower anterior teeth, that is not easy to solution. Maybe if you extraction lower anterior teeth, will be more difficult. Maybe after end of the ortho, you cannot get canine guidance. After ortho, you cannot get anterior guidance. Okay? If we possible lower arch expansion, then insert lower anterior teeth, that is the best solution for this patient. Then finally, we place on the beautiful anterior teeth aesthetic crown. That is good for the patient, good for the result, good for the smile. This is our treatment planning, our team treatment planning for this patient. This patient, 27 years old female patient, chief complaint, 1-2 missing, severe overjet. This is a panoramic X-ray. You can easily to find 1-3, 1-1, 2-1, 2-2 non-active tooth. 1-2 missing, and then this is inside the bridge. 4-1 is offset. This is my clean check. Our team is separate here, here, here. Separate bridge. Then we can control every tooth movement. Fix for the bridge cannot move anymore. But the separation, after that, we can do everything. Lower arch is expansion, upper arch expansion, and the upper molars distalization. Create a space, then retraction, upper anterior teeth. Lower anterior teeth is a control speed of the curve. Then, after that, upper anterior teeth, retraction. Before going to the Invisalign treatment, we separation on the bridge, upper long bridge. Here, separation. Then we can do everything. We can control every single tooth. Okay? Then here, take a scanning, started to control all of the tooth. My planning is this: expansion, lower canine to canine, create a space for the lower anterior teeth. After that, retraction 4-1. This is my treatment planning. And that is very important thing. After alignment also, which size is good for the smiling for this patient? At this time, we use digital smile design planning. Then so the smile design is this, and the tooth size is this. Then which size, lateral incisors, central incisors, canine, this is a smile curve, smile line, and the asymmetry or not. We have to check everything, canting, midline, everything. Then so this is a final position. Then so started to the control. Expansion canine to canine, then create a space. Lower anterior incisor is retraction. Then this patient is a bone housing, right? Have a look. Lower anterior teeth is gums is become good. At this time, we cut upper 1-2 pontics. Then place on the mini screws. Place on the mini screw. Then create a provisional restoration. After that, control lower anterior teeth, and the gum is become good. Then this is final position. That is good for the gum position. This is the initial clean check. Initial. Then this is the end of the tooth movement. Then send to the interdisciplinary doctors. Place on the fixation before we have to check smiling, digital smile design. Then this is a good size for the canine, lateral incisors, central incisors, then smile curve, canting. We check everything before place on the provisional restoration. And this is an insert for the fixture of implant and with gum graft. This is a final situation for this patient. That is good. This is a right and a left. It's a good for the shape canine to canine. This is a final position. Under this patient is a graft to the lower anterior. Here is a graft for the gum, same as upper right lateral incisors. This is the final position for this patient. Initial, final. Alignment is good. This is the final position. Midline is correct. The canine guidance and lower molars and upper molar class 1 relationship, and beautiful upper anterior teeth and upper canine. The beautiful shape, good for the prosthetic, and the gum is good. Tooth is good. Teeth alignment is good, right? But a very important thing is the face harmony for the teeth, because the patient all the time checking face inside the teeth, not only teeth only. Patient all the time checking the face integration of the teeth. The place on the canine to canine for this patient. Have a look. Comparison initial and final. This patient is after place on the upper anterior teeth. Size is good, and good for the alignment, because we based on digital smile design concept. The patient which size is good, profile is good, alignment is good, smiling is good, and the beautiful prosthetic crown. All the time we all checking for the not only alignment and teeth. Invisalign treatment is good for the control of the teeth, but not change teeth colors, teeth shapes. Teeth shape and the teeth color changes only interdisciplinary approaching. Interdisciplinary is very effective on the end of the result. Next case, anterior intrusion. Anterior intrusion, some of the time, gummy smile patient is very good for the result. So my answer is this. Anterior intrusion is very effective for the aligners. Have a look. Class 2 deep bite, the gummy smile, Invisalign, and the TAT, based on digital smile design. This patient, orthodontic treatment, deep bite and gummy smile patient. 90 years old patient. What is problem is how millimeter intrusion anterior teeth and management. This patient is retreatment, class 2 deep bite, interdisciplinary approaching, Invisalign and the TAT. Initially, this patient, chief complaint is gummy smile, 24 years old male. Then chief complaint, I'm not confident for his smile. Then, so that this patient is already received junior high school days, the braces. This is facial photos, definitely the gummy smile. Patient don't like this smile. Teeth is good, guide is good, but the integration face is not good. So we have to check not only teeth with face. That is very important thing. This is X-ray photos, panoramic X-ray and cephalometrics X-ray. As you can see, this is definitely deep bite. This is also analysis. We have to do intrusion upper 1, 2, and 2, 2. Definitely deep bite for this patient. So we have to create how millimeter intrusion, then what is change the patient face, right? Patient want to know how change my face after orthodontic treatment. How millimeter intrusion for my teeth? Patient want to know, because this patient already received orthodontic treatment since junior high school days. Then so after that, extrusion, anterior teeth. Then patient just a little bit scared, fear. If read orthodontic treatment, but my chief complaint is improve or not. But if using for the technologies, the before treatment, our team showing patient images. That is technologies. Have a look. Initial phase integration clean check. Patient understood before tooth movement. This is final position. Is it possible or not? I create a treatment planning from anatomical data, cone beam, CT, and X-ray photos. This is predictably tooth movement. I check anterior teeth axis. I check for the root shape. I check everything. This intrusion is possible. Then I create this clean check. Then I saw a patient. Started to orthodontic treatment aligners with TAT. Insert TAT center point here. Then using elastic. Same as this article, interdisciplinary alignment treatment on the short face patient. Then place on the TAT here, here. Then insert aligners using elastic like this over the aligners. Intrusion upper anterior teeth. Like this. That is very simple. Patient wear the aligners, then after that using elastic. Only this. Very simple. Patient anterior teeth is going to up. Intrusion, intrusion, intrusion. This is initial imaging, and this is a final imaging. Okay? Initial TAT intrusion and the detailing. This is comparison initial and final. After that, we do digital smile design. Then what is this? This is crown lengthening surgical guide, double margin crown lengthening. What is this? This patient is a chief complaint is gummy smile. So we do orthodontic treatment intrusion. After that, perio surgery. That is good for the effect, specialty gummy smile patient. Upper margin is bone, middle margin is gum margin. This is very effective. If you want, take a scanning data, send to the digital smile design. The DSD 3D crown lengthening guide is very predictable. This is a model of 3D printer. This is a guide, the crown lengthening guide, double margin guide. Insert this. Then send to the periodontist. Periodontist check for the pocket. Then check for the how millimeter cut for the gum margin. Okay? Then this is after crown lengthening operation. Good. Before and after, patient is good control. Orthodontic treatment with crown lengthening. That is very good solution. Specialty gummy smile patient. Initial and final, totally different. As you can see, initially is a white color. The finally is red color. As you can see, red color is intrusion under upper anterior teeth. Next case is Invisalign high canine. Some of the time is a very difficult approaching, so like this patient. High canine and the upper anterior crown premolar extraction for aligners. 44 years old female patient come to my office. What is problem for this patient? Lower molar need extraction. What is meaning? Lower first molar some of the time is not good situation. At this time, our team is extraction lower first molars, then we control lower second molar mesial movement. Okay? This is our team. The type of the management, type 5. That is very difficult. Have a look. This patient come to my office, 44 years old female patient. Chief complaint is high canine, anterior crowding, and narrow arch. This patient is just a little bit severe crowding under very difficult situation. This patient already told so the general practice dentist have to need a 4 premolar extraction. The patient understood, okay, Kenji, so I understood have to need 4 premolar extraction. Please do it. But please just hold on. I have to check for your teeth. Then my planning is different. What is good for this patient? Chief complaint is anterior crowding, high canine. Yes, I know. Narrow arch and not good smiling. Yes, I know. But we have to check more precisely. Have a look. This patient. Lower right first molars is already root treatment, but take a cone beam CT. Around the root area, this is a big defect. Big defect is there. Oh, that is a severe situation. Another side, left first molars. Take a cone beam CT. Have a look. More big bone defect. This is not a good situation for this patient. Then we asked for the endodontist from my interdisciplinary endodontist. Is this possible to prevent and extraction? How do you think? My endodontist talk about me. It's possible, but not long time stabilities. Root canal treatment is possible, but no long stability this teeth. Okay. Our team planning is this. Extraction lower first molars, both of side, right and left lower first molars. Then place on the implant with GBR, bone graft. This is a most common approaching, most normal approaching. Bone graft and place on the, after that place on the implant. Then additional extraction lower 34, lower 44. Okay? This is a planning 1. GBR plus implant with additional extraction 34 and 44. But this is a normally. Normal interdisciplinary approaching. Planning 2. Preparation, second premolars, preparation, second molars, then insert bridge, then additional extraction 3, 4, and 4, 4. Yes, but this is a normal. Yes. Insert bridge. Yes, that is normal. But how do you think? Plan 1, Plan 2. Additional extraction 34 and 44. Lower right and left first premolar. Additional extraction needed. That is not ideal approaching, right? If we create more good result, it's planning 3. Planning 3 is this. Extraction first molars, using orthodontic treatment, space closing, distal movement, second premolars, medial movement, second molars, and no additional extraction 3, 4, 4, 4. That is amazing. That is ideal approaching. Because after extraction, first molar, both of sides, no additional prosthetic approaching. Every single tooth is natural tooth. If possible, that is ideal approaching. Space closing all of the tooth from aligners. Then no additional extraction 3, 4, and 4, 4. I explain for every single planning, Plan 1, Plan 2, Plan 3, and the benefit and non-benefit, merit and demerit, with what is good. For example, bridge is very faster. Planning 2 is very faster. Preparation 2 teeth, then next week or 2 weeks later, bridge is insert your teeth, and extraction additional 3 and 4, 3, 4 and 4, 4, then started Invisalign treatment. Planning 1 implant is bone, GBR, after that implant, just take a long time, but this is normal. Planning 3 is the most take time because all treatment is orthodontic treatment, but more benefit for your teeth because no bridges, no implant, and no additional first premolar extraction. Which planning is you needed? Patient decide on planning 3. Okay. Our team published on JCO article 2014. At this time, we use Invisalign treatment and we use Acceleradent, vibration acceleration device. Vibration is a more high potential for the blood supply is very high, easy to control movement for the teeth. Then same as this for this patient, first lower molars is we need it for the endodontist, but the endodontist talk about these teeth in no long-term stability. Okay, the implant or bridge, no. Our team is decide on this planning. All orthodontics treatment, then space closing. No additional extraction, 34 and 44. Medialization the molars, distalization the premolars. Then we select, decide on the appliance is aligners. The patient accepts aligner orthodontics. Then we start for this patient. Of course, we check all the time before tooth movement, the face integration clean check. Which position is patient needed? Canine position and the lateral incisors position and the midline, everything. We face the integration, the clean check, understood the right position. This position is good or not. Easy to checking, okay? Then more detailing. Initially, is create position, the face and the clean check. That is very important thing. After that, detailing. This is a detailing. Medialization, second molars, premolars, distalization, like this sequential tooth movement, not simultaneous tooth movement, right? Then we control all of the teeth without not additional wisdom tooth extraction. Post extraction, big defect. The patient is just a little bit sad. Kenji, this is okay? Lower molars is missed. Cannot bite anymore. Yes, I know. Upper first premolar extraction. Cannot bite anymore. Yes, I know. But please image the ideal goal. We go straight, only this. The patient accepts, okay, let's do it. Started to the orthodontic treatment with aligners. Here is controlled only aligners. Have a look. Upper premolars extraction, canine is controlled, good for the control, already space closing. On the lower side is a premolars, distalized. Molars is mesial movement. Space is going to close, going to close. Space closing like this. Detailing. That is amazing, right? Aligner is very good potential. The molar mesial movement. This is another view. Initial post-extraction started to control mesial movement, space closing. Alignment. This is a final situation. Good. This is anchorage control ideas. Control of the tooth, we have to check anchorage management. The post-extraction, which teeth is anchorage? So I have this teeth is anchorage. Wisdom tooth and first premolar to first premolars. This is anchorage. And we only control second molars, second premolars, only. Then going to space closing like this, and setting a dual way attachment. Think about biomechanics. Attachment is not only one side. Some of the time, here, this and this, okay? Not only one way. Space closing. Yes. Once leveling is finished, performing vertical control and for that reason, keep the aligner from become deformed. Okay? That is very important thing. End of the ortho. Space closing for the lower molar side. Then midlines collect and remind for the wisdom tooth. Good for the control. End of the tooth movement with this patient. Then send back to the interdisciplinary doctors. Doctor is watching. Oh, no place on the implant, no place on the bridge. This is the quality control, facial, smiling, guidance, everything. At this time, take a movie is very good for the documentation. Okay? Our team is many of the time take movies. That is very, very good. After interdisciplinary approaching, lower molar is placed on the crown. This is the final situation. Midlines collect, is a canine guide, and the molars is good for the control. Relationship. This is a comparison initial and final. Comparison initial and final. The bone situation is definitely good, right? We take a cone beam CT, then the position of the bone is good. This is cephalometrics comparison that is very nice. This is 2 years retention. 2 years retention is a tooth is very stable. No relapsation. This is good for the guidance of the canine, good of the guidance for the anterior. Anterior teeth is very good for the position, not relapse. Okay. This is the 2 years retention, a beautiful smile, and the canine, and the smile line, smile frame is perfect. Comparison initial and final, totally different. This patient is no additional lower premolar extraction, and this patient is good for the result and continued time for the retention. This is the initial, final 2 years retention and a beautiful smile in mind. Okay. This is very difficult approaching, but today is no time. Is we have to. Next case. Next case is a very exciting case. So my master, my mentor, Dr. Bernard Shoup, he is published on the International Orthodontics Journal 2010. The title is this article, Invisalign Treatment of Patient with Craniomandibular Disorder. What is meaning craniomandibular disorder? TM joint, temporomandibular joint problem, very difficult to open the mouth, pain on the joint and the muscle, neck pain, back pain, everything. Patient is very discomfortable situation. At this time, the Dr. Bernard Shoup told us, please do two-phase treatment. What is this two-phase treatment? CMD patient is a joint problem, muscle problem, and neck pain and back pain. According to this article, the joint is very important thing. Condyle and disc. Disc is very important thing, the position. The right position with condyle is good. If displacement is not good, right? The red color is disc. This is ideal position. Occlusion is good, condyle position is good, and disc position is good. But this is not good. CO not equal CR patient. Occlusion is good. Disc is good. That is ideal position. But some of the time, occlusion is good, but the condyle position, disc position is not good. How we do like this situation? I will show you interdisciplinary approaching, and this patient chief complaint, neck pain, back pain, and aesthetic problems. 27 years old female patient. The patient come to my office initially like this. Have a look. This patient, midline is deviation. Midline is a deviation to the left, not for the same. And the lower anterior teeth is spaced. This is facial photos. As you can see, lower mandible is shift to the left. Definitely shift to the left. This is a OPG. As you can see, lower first molars, 36, the 46 is already extracted. Then place on the bridge. And you can see lower anterior teeth is spaced, midline is deviation. And you can see, please check for the condyle. Lower right condyle just a little bit forward position, and not the same the shape right and the left. This is the initial cephalometrics X-ray. We have to check precisely. Then this is a condyle. position from cone beam CT data. Cone beam CT data is easy to checking for the bone situation. Right side condyle just a little bit forward. Okay? This is a condyle from a right side. Just a little bit forward. Okay? This is MRI, magnetical analysis. You can see right side condyle is just a little bit limitation movement, not smooth. Limitation movement like this. Okay? This is the left side. Left side is clicking. Okay? Not smooth, not like this. Like this, okay? This patient is very difficult to open the mouth. And this red zone is a pain area. Joint, muscle, and this line is a pain area. This patient is a big 3 point is painful. Muscle, joint, head, neck, back pain, like this. So our team is create a sprint initially, because already I told you last session, so our team is normally initial time functional analysis. If patient have any problem, we treat it first, functional problem. This using the sprint, name is COPA. Why we call the name the COPA? Craniomandibular Orthopedic Positional Appliance. COPA. COPA sprint insert for this patient. Insert for this patient, please have a look. Already this patient midline is correct. And as you can see, this patient is upper right canine and the lower right canine is contact. This canine is premature contact. Hit premature contact canine, upper right and lower right. Then mandible shift to the left. Okay? Initially, close the mouth, upper right canine contact, premature contact, then go to the right. This COPA sprint is a block. Shift to the mandibular left. Okay? Naturally closing, relaxation, hit canine, then stabilize this position, not going to the right, not going to the left. Okay? This is a keep stabilization position. 3 months later, still using sprint for this patient. Have a look, condyle position. The keep ideal position after sprint. The patient in the sprint is good keep position for the condyle. Please compare this initial and final. Totally different. After this, we take MRI. Have a look. This is the right side. Smooth movement. Comparison initial and final. Initial just little bit limitation, block. But after sprint, movement is very smooth. What is meaning? Easy to open and close the mouth. This is left side. Left side is movement for the softly and not limitation. Comparison initial and final. Initial is lock, then move, lock, then move. This is a limitation movement. That is totally different initial and final jaw movement. After sprint therapy, the patient pain-free and the jaw is good for the movement. Then we started to the next step. Have a look. This patient, lower molar is bridge, and this is a copper splint. Blue color is splint height. Red color is bridge height. Then we order to laboratories and we order to interdisciplinary prosthodontist doctors. Please keep same height provisional restoration. Same height, that is very important thing. Same height is keep pain-free position on the condyle. Have a look, right canine, the same, okay? Before going to undesirable position, keep stabilize. This condyle is comfortable position. Then remove all the bridge, then create new provisional restoration and the same height, bridge with copper splint. This is provisional restoration, and this bite is very important thing. Okay? Insert patient mouth, provisional restoration. Patient is keep midlines correct, keep comfortable pain-free position, then take Invisalign implant, Invisalign scanning procedures. This is a fast planning. This is a fast phase. Don't move the molars. That is very important thing. If movement molars change the condyle position, will be easy to back for the problem joint position. Don't move the molar. That move height position is very, very important thing because a comfortable joint position. So I order to Invisalign company, please don't move the molars. Keep molars. Only control premolar to premolars. Okay? That is amazing. If using to the multi-bracket system, cannot do like this. Only digital orthodontics. Digital ortho is we can easy to order movement this teeth, don't move this teeth. Okay? Then phase one. Phase one is don't move the molars, only control premolar to premolars. Then keep patient joint comfortable position. That is very important thing. Okay, let's start the first phase. Aligner is set. Okay, the patient is keep pain-free position. End of the first phase. Have a look. Midline is correct, and the space is just a little bit create, and the molars is never controlled. Patient during phase one, no pain. Good condyle position and good for the muscle joint. Everything is stable. End of the first phase, we take X-ray, check root position. Okay. So we step up second phase. This is wonderful article. My friend is Dr. Aldo from Italy. This article published on the 2006 JCO. What is meaning this article? Pre-restorative treatment with the Invisalign system. Have a look. Left side is before ortho. Missing lower first molar. Oh, same this case, right? And the spacing lower anterior teeth. Oh, same. Then control aligner orthodontic, uprighting second molars, space closing lower anterior teeth. After also place on the implant, both of sides. Very similar to my case. discussion. This case demonstrates how the Invisalign system can be successfully using for the molar intrusion and uprighting. Distal lower molar uprighting was achieved with mesial shift on the entire tooth movement. Like this situation, only uprighting is not enough because the only uprighting will be premature contact, only second molars. Will be open bite, another teeth. Have to need uprighting with intrusion. That is very important thing. But the Invisalign system, this is very effective. This case demonstration how the Invisalign system can be successfully using the molar intrusion and the uprighting. Okay, we do. Phase 2, second phase, we do everything. Separation the pontic. Then lower premolar mesialization, create a space first molars, because that we create a space, after that insert implant. I want to insert implant. Okay? This is not good because a short space, no needed. So we want to control everything, alignment anterior teeth, and the lower premolar mesial movement. After that, place on the implant. Have a look. Lower premolars put on attachment, labial and lingual. That is very effective tooth control for this patient. That is a key of the success. Alignment this. Okay, let's go to the tooth movement. Separate lower bridge pontics. Then started to the phase 2. Started to the second premolar mesialization, only aligners like this. Yes. This is placed on the implant after create a space. After create a space, I send to the implantologist dentist, place on the good implant. Invisalign orthodontic treatment time is first phase is 6 months. Second phase is 8 months. Total orthodontic treatment time is just 14 months. 1 year plus 2 months. Create a space, place on the implant. This is planning to the place on the implant. Good works. Thanks a lot for the interdisciplinary doctors. This is a place on the implant and premolar, second premolars, and second molars is every single teeth is good, not fixation, not bridge. Every single teeth is separate. Insert the mouth. This is the final situation. Final restorative is lower molars and premolars. Midlines correct. Canine guidance achieved. Of course, anterior guidance achieved. And no more shift. Lower mandible. Lower mandible, we have to check comparison initial and the final. Initial, totally different for the final position. And this is the face. This face is initially. Initially, definitely shift to the left of the mandible. Have a look. This is the final. Final is mandible is correct. Then smiling is totally different. Initial and the final, not only alignment teeth. This patient, no pain at joint, no pain at muscle, no headache, no backache, no pain ache, comfortable, and the occlusion is good. Space create. After that, place on the implant. Smiling is good. Achieve the canine guidance. Achieve the anterior guidance. Everything. Invisalign treatment is not only simple, easy case. Invisalign treatment is now, as you can see, more severe case, more complex case. We can do everything. This is the final situation. Final smile is a beautiful smile, and no shift to the mandible. Midline is correct. Canine position is good. Arch, smile arch and frame is good. We achieved canine guidance. 2 years retention. End of the ortho started to the retention. 2 years retention. The patient asked to me, "Hi, Dr. Kenji, can I do the more beautiful, more aesthetic approaching? What do you want?" "Yes, I want to do laminate veneer, upper 1.4 to 3.4, if you can." If you want, it's okay, no problem, because the 2 years retention is still good, very stable, no problem. How do you think your jaw, your headache, and neck pain, backache, how do you think? Nothing. Very, very comfortable. Okay, I will recommendation the very good prosthetic doctors. The patient go to the prosthetic doctors, place on the veneers up 1.4 to 2.4. Occlusion is good, condyle position is good, disc position is good, canine guidance is good, anterior guidance is good. Create a space and insert the implant, posterior support is good. You can do everything because it's very stable. Patient want to more positive approaching. Okay, no problem. Then this patient, after retention, this very, very beautiful smiling and a beautiful occlusion and very happy because of no pain. The pain is very problem, right? This is a comparison initial CO not equal to CR situation, and the middle of the photo is end of the ortho and place on the implant, no pain, CO equal CR position. Final one, retention plus veneer, no pain, CO equal CR. Smiling is good, wonderful. Retention after 5 years, 2 years plus 5 years, totally 7 years retention. Still good. After 5 years retention, canine, midline, occlusion, canine guidance, still good, no pain, the jaw, mandible position is good. This is after 5 years retention, the patient still good. This is the initial 40 months later, end of the ortho, place on the implant, CO equal to CR. Then 2 years retention, place on the veneers, plus 5 years retention, still good. This is Invisalign system potential. If you have an idea, if you have an experience, you have to learn clean check control and the clean check approaching. You can do same thing because you and me we are friends and we are already colleagues. I support you. If you have questions, please feel free ask to me. The many of the case is very difficult. But if you have a plan, idea, you can do everything. Okay? And I have a YouTube channel. If you have a problem, please check my YouTube channel. And this one is digital smile design. So the Christian coachman all the time talking, what is the DSD? The DSD is not only anterior teeth control, not only anterior teeth, everything. The teeth, occlusion, position, and the face, and the condyle, everything. I visited to the his office, Sao Paulo Well Clinic. That is amazing. That is a real, the good clinic. So that I met his father, I met his friend Renato. So that I'm very respectable his works. That is amazing. So then I started to the digital smart design approaching. Then after that, I visit to the Madrid, Spain, Digital Smart Design Planning Center. So the DSD Planning Center now is a very wonderful education centers and a wonderful place for the planning for the tooth movement and the tooth position. If you want to more expand, please collaboration and digital smart designs. So what is DSD? DSD is not only teeth alignment.
All about the new
Okay?
5D. Let's see what they have. I'm very excited. Let's go.
So the Christian coachman
I'm here with my
and
dear
me
friend Kenji.
is
a big fan of Kenji's work. Definitely one of the top orthodontists when it comes to aligners. So for me, it's a great honor, great pleasure to be creating this program with Kenji. And we're going to start in Tokyo. That's the first one. But the idea, of course, is to expand this. But I really hope that the orthodontic aligner community in Asia in general, not only Japan, but I hope that all our colleagues in East Asia will join us in Tokyo for this unique pioneering event that combines the DSD workflow with Invisalign strategies.
So DSD concept is not only anterior teeth aesthetics. Our team concept, DSD, our concept is using digital tool, then we can do more predictable diagnostic, treatment planning, and the patient and all staff better communication and good result for the patient. This is our concept, why we use digital smart design, integration in Invisalign. This is our answers. 2020, our team is more positive using digital smart design collaboration in Invisalign. Have a look. This patient is want to start orthodontic treatment. But this patient is a young generation time, 20 years ago, at this time drop out multi-bracket braces because very tough time. Then cannot continue his braces. Then the patient come again to my clinic. Then she want to do Invisalign treatment. But the patient just a little bit fear because once a time it's drop out. Okay, at this time I will do very wonderful tool. Better communication for the patient. What is better communication for the patient? This is the initial photos. We take photos, patient initial informations, photos, and take photos and the face photos. Yes. This is a smiling photos. Yes. Take photos. Nowadays, not only photos. Take movies using iPhone. That is more good for the documentation. Smiling and moving for the lip, we can understand which position is good or not. Easy to get the documentation. Okay, I saw your lower teeth. I saw your second premolars. Please laughing, please smiling, please talking. We get a good data. Of course, then we take scanning procedures and we get it for the STL data for this patient. And take a facial STL data too. That is very simply and easy. Put on this one, facial scanning. Just few seconds. Like this, like this, like this. Then finish. Amazing. Then we get it. Safety, the fast, precisely. This is, I get patient facial STL data. This is a OPG and cephalometrics data. All data get it. Eye planning. Yes, of course. Clean check too. But this patient, one thing, last time is dropout. Okay, I will create motivational mock-up. Do you know what is meaning? Motivational mock-up. Create this digital data. If you have a scan, if you have a printer, easy to create your own motivational mock-up. This is the ideal treatment planning initially, okay? Then ideal treatment plan, ideal treatment position. After that, create motivational mock-up. Motivational mock-up is just a little bit more front because not teeth movement. Have a look. This is motivational mock-up, okay? Create. This is a motivational mock-up, okay? Motivational mock-up is a put on this second appointment, not tooth movement, the before tooth movement. Patient initial time take a data, okay? Then I create a treatment planning. Then I create motivational mock-up from digital data, okay? Then all the tools I create, yes, root, crown, the gum, everything. Then I planning what is good position. Everything. Root, crown, and the gum, and the bone, and the condyle position, and the face, all data integration. Okay? All data integration. Finally, the facial STL data. Then we understood everything. Which tooth position is better smiling for this patient? Now understood everything. Okay? Then I planning which position is good or not. Okay, this position is good. Then we create another thing. What is this? Another thing is this. Create the face, okay? After that, clean check. Okay? Initially, not only clean check. Initially, face, integration, teeth, and the bone, and the root, everything. Then we create motivational mock-up. This is before. This is before coming to the patient. This is a second appointment. Second appointment is want to put on the motivational mock-up. So you can do. So sorry.
皆さんごきげんよう、小島です。今日はですね、
これちょっと動画を少しだけ進めてもらっていいですか。ちょっとだけ進めてもらっていいですか。そうですね。そのままスーッと進めてください。そのままスーッともっとはいはいもっとOK もっと
こういうの。
This is motivational mock-up. Okay? Have a look. Okay, stop please. This is a motivational mock-up. This patient's second appointment. This is a shell. Okay? Create a 3D printer. Just little bit bonding. Not final. Temporarily bonded. Just little bit. Okay, this is a shell. Create motivational mock-up data from the data. Just little bit. Then put on this patient teeth. Put on this. No orthodontic treatment. No aligner. Just second appointment. Put on the shell. Light curing, finish. Okay? This is a separate canine to canine, premolar to molar, premolar to molar. 3 parts. ちょっと進めてもらっていいですか。This is a front teeth, only front. This is a canine to canine. This is a left side. Then light curing, very easy, very fast, very safety. Light curing, and after take movies, easy to remove because I just put on this. Not final bonding, very easy. はい、ありがとうございます。This is put on this motivational mock-up. Then, very important thing, don't take a mirror. Very important thing. Patient watching the mirrors is not good. Very important thing, don't look at the mirror. Then take photos, take movies. Okay? Then comparison initial and final. Don't give to the mirror. Okay? End of the motivational mock-up. End of the patient. Then move the place. Then take photos. Take movies. Please don't look the mirror. Don't look the mirror. Okay? でちょっと早めてもらっていいですか。そのまま早めてください。The patient is bring to the place of the shooting. Okay? Patient don't understood how change her smiling. She never know her new teeth. Okay. Then so our team is take a shooting. The patient's new smiling, okay? New smiling, take a photos. ちょっと早めてもらっていいですか。We take photos, not only photos, take a movie too. Take movies, take photos. The patient is no realized new smiling, okay? Then so that we get it, the first appointment movie data, and we get it second appointment movie data. Then please watching just movies. Okay? We never explain. Okay? じゃあ止めてください。ちょっと音を大きくしてもらってもいいですか、次は。Then our team is promotion these movies for the patients. ちょっと音を大きくしてもらってもいいですか。This is emotion. The patient have a heart. So the orthodontist and the dentist, our colleagues is many of the part is science. We need a scientific because we are scientists and doctors. But the patient is not only scientific aspect. Patient have a mind, patient have a heart, and the patient have a happy, patient have very sad. So now we use the technologies, take a scanning and the computer simulation. Then we now showing for the patient my ideas. After orthodontic treatment, then if patient want to do non-preparation veneers, my planning is this. The patient is watching the PC. Okay, this is a computer graphic. Okay. But if inside patient mouth, very realities, the patient motivation is become very high. If for the orthodontic treatment, and interdisciplinary approaching, some of the time, long-time treatment, 1 year, or some of the time, 2 years. But if patient keep the high motivation, good for the communication, our team and the patient. That is the power of the emotion dentistry. The Christian Coachman and the Digital Smile Design DSD team is give to the this wonderful techniques. Then I using for the emotional dentistry based on scientists, based on the science. Okay. The patient is now started for the orthodontic treatment. Then we are talking all the time the same goal. The technologies is every year, every day, every moment is still high. Align Technology is amazing companies. I love it because they are very cool and they are very have a passion because basically help for the patient. The please for the joins our field and Align Technology and your clinic is a become good future using technologies and the science and the heart. So that we are already colleagues. So if using for the iTero scanning, new iTero 5D Element Plus, that is amazing, very fast. I love it. I buying. It's a 4 new iTero. Please using the new one, then take a digital good planning, then start it for your journeys. Why? How can we do the good for the patient management or patient? How many patients coming to your clinic? 3 things. 1, science. 2, technologies. 3 is your mind. Okay, so today's my lecture is finished. Thanks a lot. Obrigado. Muchas gracias attending to my lectures. So I hope see you soon, face to face, so for your face. And I will visit for the next year, 2022. So I will go to the SPO and see you again and see you soon for your wonderful journey. Thanks a lot. Obrigado. Muchas gracias. Bye bye.
Thank you, Dr. Ojima, for your participation. It is always important to hear from professionals from all over the world. So this experience is as enriching as possible to all of you in terms of knowledge. Now, our final break, and when we come back, we will have the final part of our event. We will compare a clinical case using CleanCheck. And to end the forum, we will hear the winners from the best cases chosen by you. We'll be back in a minute. We are back, and now we will start our clean check session. Dr. Almir will compare the evolution of the treatment of the same patient under the perspective of each of our guests. Doctor, is that right?
That's right, Renata, exactly. We invited our speakers to all study the same case and asked each one to put together a treatment plan using ClinCheck. In the end, we'll compare all three results.
Dr. Almir, so let's get started.
So now I'd like to invite our first guest, Dr. Guilherme Tizin, who headed this case, which is published in our global gallery. Afterwards, we'll hear some considerations from Drs. Martin Pedernera and Kenji Ojima. Guilherme, take it away.
Hello, Invisalign Doctor. I'm Guilherme Tizin. I'm from Florianópolis, Santa Catarina in Brazil. And I'm a faculty of Align for Latin America. It's an immense pleasure to be here participating today of Align Forum Latam, this major event uniting all Invisalign doctors in Latin America. And I'm here today to participate in an activity that fills me with joy. Clean check around the world. This is an activity that has already happened in the past and I thought it was amazing. The same patient, the same clean check, where several experienced doctors will give their opinions and the ways, there are different approaches for the treatment of that malocclusion. So I separated a case that I treated. I want to tell you my considerations, and then we'll see a star group of doctors who will also want to give their contributions on the treatment of this case. After all, different minds think better than a single mind, right? So let's see what they have to offer us, right? Shall we? So for this activity on Clean Check around the world, I will show the clinical case I chose, and then we will have Dr. Martin Pedernera, Dr. Mariano Santamaria, and Dr. Kenji Ojima will also give their considerations on it. Let's take a look at the case. Let's go. Like I said before, different heads may have different ideas, different solutions, and we know that there are many ways that can lead to Rome, right? So we'll see different approaches, and I'm sure that all of them will have great results. They will have great clinical resolutions. But it's great to have the opportunity to see how each one can contribute, because it will open up my options in terms of therapeutic ideas. The case I chose here today is a case that was previously treated at my office, that was even published in Align's Global Gallery under number 1098. So you can take a look at the case there if you'd like. This case was sent to me by the patient's clinical dentist. The patient had TMD that was symptom-free and the lower third of the face was balanced. This is an adult patient who was 32 years old. The patient had a recession in the lower incisor due to occlusal trauma, class 2, division 2, left subdivision. That is the full class 2 on the left side, right side class 1. A deep bite. This was the overbite that was causing the trauma on the periodontal region in anterior-inferior region, and crowding on both arches. Here we can see in this photography here in these images the major trauma that we have here in the region of the lower incisors, okay? Here in this initial x-ray, we can see roots with a good size. We see the absence of any major bone pathologies. And here I want to show you a part of my therapeutic intentions. That is, based on the fact that the lower third of the patient's face was balanced, the patient had a slight horizontal trend, I decided to occlude posterior teeth and intrude anterior teeth, with more emphasis on the lower region, not to impair the patient's smile line. The same way to reduce the malocclusion, I chose for a sequential distalization with intermaxillary bands class 2. Here in the profile radiography, we can see a balanced growth tending to horizontal. We see very retro-inclined upper incisors and also lower incisors that are retro-inclined. We also see in this image here my intention of doing the intrusion of both incisors and to resolve this retro-inclination in both arches. In the cephalometric analysis, we can see the figures proving the data I just mentioned. A and B 4.5, 1 point NA -2 degrees, 1 dash NA 1 millimeter, 1 dot NA and B 7 degrees, 1 dash NB 1 millimeter, IMPA 82 degrees, SNGOGN 29 degrees, and upper and lower lips a little behind Steiner's S line. So here we can see my clean check, which was done in 2018 when the patient came to my office. We will see that at that time I preferred some attachments that I wouldn't use today, and we'll discuss that in a minute. I also preferred some overcorrections. We already had the G5 protocol. However, we'll see that G8 will provide a great improvement in these overcorrections that back then were relevant in my view. So let's take a look here. I incorporated a lot of torque from the upper incisors, a lot of vertical overcorrection, a posterior extrusion, and anterior intrusion. On the left side, the class 2 band to then correct this relation via sequential distalization. At the time, the optimized attachments were smaller, and the amplitude of the anterior-posterior vertical correction suggested me that I should use those attachments. But let's take a look here. Let's see in these 87 stages and how currently we would treat it, okay? In any case, here we can see that we have the heavy occlusal context, posterior occlusal context that are resulting from my correction, and here how the treatment evolved throughout this first sequence of aligners. Please look how the case is going well. It's having good evolution, progressing well. It's being well conducted in my opinion, okay? And here I needed an additional stage. I needed a sequence for refinement with 29 additional stages. I improved the torque on the incisors and improved intercuspidation in the posterior region. Through this additional sequence of aligners, I was able to, at the end of treatment, get good smile aesthetics and a good relation between alignment in the upper arches and the lower arches, and also a good relation between the arches. Midlines that are coinciding, the exaggerated overbite was corrected, and the class 2 on the left side as well. So here we have an analysis of the patient's smile, and here we have an image from the final X-ray. Here I have the final teleradiography, and here I have the comparison between the panoramic X-ray at the start and at the end, the initial and final. Here, as you can see, I used as a precaution fixed contentions, fixed retainers, upper and lower, but in addition to Vivera, covering it with bite ramps, okay? So this is the cephalometric analysis. We see an improvement in the inclination of lower and upper incisors. We see a better interincisal relation. An A and B, it went down from 4.5 to 4. 1.NA went from -2 to 7. 1-NA remained at 1 millimeter. 1.NB went to 18 degrees. 1-NB went up to 3. IMPA from 82 went to 94. SNGOGN had a minor change. And also the lips based on Steiner's S-line. Total cephalometric overlap, showing here in gray the teeth at the beginning of the treatment, and in yellow, beige, the teeth at the end, as well as the outline in red at the end. We had few skeletal changes. After all, the patient did not have growth. And mandibular cephalometric overlap, showing the major intrusion that the lower incisor was subjected to. Here we have a comparison on the front and side left view at the start and at the end of the treatment. This stability of the correction can be measured here with the post-treatment 1-year follow-up with the patient. Here we can see the stability in the correction, both vertical and anterior-posterior. Then we have the question, over time, did my clean check change? Of course it did. After all, a line in the Invisalign system evolve constantly. They change constantly. And this evolution indeed leads my treatment to be more predictable and more assertive, faster. Isn't that true? One thing that has truly changed in my point of view, if I were to treat this patient again, the larger optimized attachments, because back in 2019, these attachments were increased in size. So the patient that I just showed you was treated in 2 years of treatment. So I started in 2018, so in 2020 I was done. 2021 we have the 1-year follow-up. But early in 2021 I have the 1-year follow-up. But if I were to treat the patient today, 2021, I would use the optimized attachments. I would also use the G8 protocol with Smart Force Aligner activation, particularly with the resources that have improved the predictability of the G5 protocol. Why? Because now I have calibrated forces for the intrusion of the anterior battery, both on the upper and the lower portion. So these forces now are being smart for each group of teeth and for each region where the teeth are in the arches. The curvus P is better leveled. In the same way, we have attachments to optimize the intrusion in the lower arches. And of course, the automated appearance of precision bite ramps. Why? Because we were able to prove that the lower intrusion is a lot more predictable when these resources are available. So let's take a look. How would I do this clean check currently? Let's take a look. So everyone, this is the way the clean check came back in the first moment. After submitting the same case, in the first stage to align. So we can see here that a few changes have come up, right? Even though there's the same complexity for the treatment of this dip bite. Still, in this first moment, the technician did not correct the class 2 on the left side. But let's go. What would I change here for this treatment? The first thing, I'd like to have an attachment on the lateral incisor. As praxis, I like to have attachments on the lateral teeth. If I don't have it, I pay attention. Here there's the necessity for intrusion of the central incisors to maintain the aligner well fit in this position to correct torque. So I would add an attachment. I would add an attachment to the canine as well to optimize the intrusion in this region, to provide more retention by the aligner here. And particularly here, of course, we need to correct class 2. And to correct class 2, I need to use intermaxillary bands. Sadly, I cannot fit the intermaxillary bands here with this type of attachment. So I will have to change them. But take a look here. Here we have resources such as the G8 protocol, smart force activation. How do I know that? There are these designs of new attachments, of more robust attachments. And of course, if I click here, I can look at the table of movements. What is crossed over? Here we see smart force aligner activation for anterior superior intrusion and anterior lower intrusion. Another interesting thing here that we can look at is that, take a look. Here there is already as something that is considered default for a practice like this, for a treatment like this, the heavy interocclusal contacts in the posterior region and the absence of contact in the anterior region, both for the lower and upper arch. Isn't that great? What else would I change? Since I told you that I would change attachments here and class 2 blends on the left side, I would provide a little more torque on the upper incisors. Why? Because this is a class 2, so the more torque I have, I would have to do this, even with fixed orthodontics. So here I will provide more torque. I will ask the technician 8 additional degrees of torque, in addition to asking for a sequential distalization associated with a static start. So these upper incisors will already start moving from the start of the treatment. Let's see how this can check move for the treatment now with the correction of sequential distalization. So let's take a look here. So you can edit that first stage, the transition that we had here. These aligners in blue, alright? So let's cut it here, okay? Let's just start here. You can cut those points. I'll try to show you, but it's just a few seconds back. I'll start here again, okay? So this is the new clean check that has brought with it the buttons and the hooks to use the class 2 bands. Of course, here we'll need attachments. No, because the main movement here is an extrusion. If we had any rotation, any need for torque, I could add an attachment. But since the main movement is the extrusion, the band, if it is applied here at the button, will make it unnecessary to use an attachment here. Here I needed to change that attachment for root control. I added this attachment here, this horizontal attachment, 4 millimeters. And here, as I mentioned to you, as I said before, an attachment, another attachment. Here it's displaced towards distal and cervical as a result of the patient's bite, of the deep bite that the patient has. Alright, everyone? So take a look. Please notice how my clean check has changed quite a bit. And look at the number of stages is quite different. Let's see what we have here. the entire sequential distalization. The second molar, I don't need to move the attachment now because the movement is a distalization. If I had any major rotations, the algorithm would have added an attachment there, optimized with a larger size. And now CleanCheck is assertive, it's faster for me to work, and of course there's no need for that major overcorrection, right? I have worked in a few cases with the GA protocol and it works wonderfully. Alright, that is why the protocol is more and more reliable. I joke around with the following: what was good has become even better, right? So now I will turn the floor to my other colleagues, to the other doctors, because I'm really excited to see what will they have to complement in the treatment of these patients. Let's take a look. Let's hear what they have to tell us. Well, here we're going to analyze the clinical case, but with the modifications that I'm going to plan for the treatment of this particular case. Well, first we want to see what case this is. Let's start by analyzing the photos of the patient. This is an adult male patient. Has a lower third that is diminished and low support for the lower lip. I can see that the patient has a retrusive profile, so it's a class 2 patient. It's a class 2 second division, as we can see, with a subdivision on the left side. So this is a class 2 on the left side, a full class 2, and a class 1 on the other side. If you know me that I like these cases where there's this type of deviation, which we can analyze here, where we can see that the lower midline is not corresponding to the upper midline. It's to the left, shifted to the left by about 2 millimeters. We have even 3 millimeters. If we look here, if we start from the upper midline, we have about 3 millimeters approximately of a difference between the midlines. Let's take a look if we can consider that the upper or lower midline is deviated, so we need a picture with a smile like the one we have here. So we have in this picture, I have to consider that the upper midline is quite centered on the face. It's centered with the facial midline. Therefore, I have to think that in this case, the lower midline is shifted to the left of the patient, which makes me think that I want to do a differential diagnosis, or at least try to think and see if the patient doesn't have a lateral mandibular deviation to the left. Looking at his face with his beard makes it a little more difficult to determine that, but it would be good to try to at least manipulate this case and see if the jaw can be centered and see if we can move to a bilateral class 2. This would be the first stage. So let's work with the CleanCheck in this particular case. So I need to consider as the first point here, when I'm looking at the CleanCheck, seeing if this is an adequate assembly. And something that helped me and something that I do, the way I do this, the way I do all my clinical cases, is to take the initial photos, the occlusal pictures with the marks. It will help me to see if these contacts coincide with what I have in the picture, in the photo, the CleanCheck and the photos. In this case, I do not have images with articulated paper, so let's do this assembly on the case. Let's look, because frankly, the lateral images, I can see that this fits quite well with the reality of what I can see in the photos, both the lateral photos and the frontal photos. So let's talk about this case, class 2 division 2 case with a severe overbite, a severe deep bite. So I have the CleanCheck here for this patient. I don't like it for a number of reasons. let's do this request together. First and foremost, I don't like it because when we're correcting the torque, which needs to be corrected, because when correcting the deep bite, we're doing it first by intruding and then changing the torque, because we know that which would be adequate was to change the torque first and then the intrusion. It's quite important to do this. Let's look at this profile X-ray. I do not have the cephalometric analysis, but this image lets us see that the root of the upper incisors is closely touching the vestibular cortical, which will make it more difficult to have an intrusion movement. First, we need to change the torque, which we will do with a proclination of the incisors and then the intrusion. That's the order which we're going to use here. Well, we will request the deep bite to be solved. How we will do it? Apart with intrusion on the upper incisors and then with the lower incisors, because it's quite severe. We see a curve of speed that's quite pronounced. So we want to intrude the lower incisors and also to intrude the upper incisors because they are in a lower plane than the other teeth. We can also see that in the panoramic X-ray. I always say, you know me, I like to look at the occlusal planes separately. On the lower occlusal plane, we see that the premolars are down here, and the canines and incisors are upper. They're over-extruded. We can do the same thing with the upper incisors. The occlusal plane and the incisors, particularly the central and lateral incisors, are dropped. They are over-extruded. So I want the intrusion of both upper and lower incisors. It is important to take into account when we're doing the intrusion of the upper incisors the image that will provide us information, the image of the smile. The image of the smile here tells us to do an upper intrusion, but carefully, not going too far. If it's a gummy smile, I would probably have 2 mini screws to do the intrusion. But when we have this degree of exposure of incisors and no gum exposure, we will request a slight intrusion on the incisors. So let's do the changes in this clinical case. I like to insist and to ask to the technicians and the CAD designers, because they are the ones that are an extension of our brain, and they are in charge of doing what our mind is thinking. So let's be good with them. I always start my indications by saying, "Dear technicians," this is a clean check. So I thank them. Thank you very much for the clean check. I would like to request the following changes. And then, here, we are following a certain order with the indications that I will ask to the technicians. So immediately I add notes. Then the changes I want to do in the upper jaw. And then the changes I want to do on the lower jaw. To always follow an order in my indications. What will I add as notes? I will add something about my clinical preferences that are not present here. I prefer, in the clean check, we have the attachments from the area number 3 or 2. 1, 2, since number 2. I like the attachments to be placed, unless we're patients who are Invisalign first, the children, I like them to have them first to start. Particularly if there are movements that will require attachments to be performed. So what I require is to have the attachments since the start, since aligner number 1. Well, and then we will start to do the correction, like in this clean check. Here we don't solve class 2. The first thing I will request is to correct this case in a sagittal manner, and I want them to correct it. The class 1, correct to class 1. I want the correction to go up to class 1. I want a full correction. How will request this? Or using distillation, sequential distillation. It's very important. If we're going to have distillation, we need to know that there's not the presence of a third molar that will prevent us from doing this movement. Since there is no third molar, we will do the correction in the second quadrant on the left side by means of sequential distillation. So, by means of sequential distillation with a 1.5 pattern, I want to use this pattern. How many millimeters will I request? So I'm asking the technician, please correct up to class 1. So how many millimeters do I have to have of distillation up to class 1? 3, 4. I want to get to a sequential distillation up to class 1. So let's start with the distillation of 2.7, and when you've arrived up to the half of its path, start the distillation of 2.6 and so on. So this is the pattern I want to be followed. So the action of distillation can cause a reaction on anterior proclination. It's a reciprocal movement that will suit me well because I want to change the torque. But let's remember, let's request it that since the start, since the beginning, since the static start, we want to have the following sequence in the anterior-superior front. First, proclination. I don't want to change the torque. I don't want a radicular palatine torque. I want the crown to be pro-inclined. So, coronal vestibular proclination. It's very important to allow the technicians to, when they have this proclination, that we will create spaces to have the correct proclination. A coronal vestibular proclination to open spaces until spaces have been actually opened. Second place. Here I'm going to ask, therefore, do not add power ridges. I don't want to have power ridges in this case. So do not use power ridges. I always like to add, do not leave any lateral incisor, upper lateral incisor without an attachment. I always like to have them with some attachment, preferably an optimized attachment if possible. And if not possible, please add a conventional attachment that is rectangular, an horizontal rectangular conventional attachment with a gum bezel at 4 millimeters closer to the incisional edge, if we can't use an optimized attachment. Following the sequence, I want to have a, after changing the torque or the inclination, I want the pure intrusion up to what point? Up to 4 millimeters, since we don't know, until we have the leveling of the occlusal plane. Third, I want the retrusion and retraction of the anterior front. Alright? So I've asked, since the start, I want at the same time to have, at the same time, we are doing the distalization. Alright, so if we're asking for the distalization of the second quadrant, at the same time we ask for a proclination. Once they are pro-inclined, we intrude them, and lastly we do the retrusion. So this is pure pattern. It's the protocol sent by Invisalign is the tier, which is torquey first, then intrusion, retrusion. I'd like to have more coronal-vestibular inclination. It's more predictable, more effective, in my opinion. Well, I like that this case already has the precision bite ramps. This will help me, frankly, to do the intrusion of lower incisors, see how they are modified and how this happens and how this helps with the lower incision. I like it. But let's look at something. I want there to be also a little bit of a sequence. Here we're doing proclination and intrusion at the same time. It's doing proclination and intrusion. So let's ask for the lower jaw that we should have the following sequence. First, proclination, and we want a coronal vestibular proclination. We want that on the incisors. Then, second, pure intrusion. Currently, you have the G8 protocol that can provide a much more predictable movement. But I want the leveling of the curve of speed to be perfect. So let's add a few other things that I like to request. Our protocol G8 will help this be much more effective. So the first request we will add is to level the curve of speed, and we will do it by the following indications. So this is the following sequence. First we're going to procline, then intrude with a pure intrusion, and then we will have the intrusion around 0.2 to 0.3 millimeters to 3.7 and 4.7. I like to give a reverse curve of speed, an anti-speed, so to speak. So we'll ask for the intrusion of the second molars. That helps to include strengthen the anchorage of 3.47 and 4.7. And we want to finish the case with strong contacts between premolars and first molars, the lower first molars, against its antagonists. I always like to have this, to have a slight overcorrection. According to the G8 protocol, they don't tell us not to do it, but I like to do it. I like to create an inverted curve of speed, so I want strong contact. Let's go back to the upper arch for a moment. I said that I wanted the sequential distalization and a distalization with a rotation. So I forgot to add the second quadrant with a half pattern. And then I will also ask at the same time that we're doing the distalization of the second quadrant, I want to add, in this case, maybe I need a little less, but I request a distal rotation by 10 degrees. This case we'll request it by 10 degrees and see what comes back. At the same time, we're doing the distalization of the second quadrant. When we're distalizing 2.6, we're going to add 10 degrees of distal rotation to the same tooth.
Bien.
Very well.
Me gusta la alineación.
I
que
like
sea
the
sin colisión, y es
alignment,
donde voy a
no
solicitarlo
collisions,
en la arcada inferior.
and I will
En la
request it
inferior
in
voy a
the
insistir que
lower
aplane la
arch.
curva de P mediante
I
las
want the
siguientes
leveling of the
indicaciones.
curve of
Prefiero la
P
segunda
following the
siguiente
following
secuencia.
indications with the
Inclinación
following sequence:
coronavesicular de incisivo.
coronal vestibular
Entonces,
proclination of
insistiré en
incisors, and I will insist
alinear
in aligning
incisivos
the incisors, the lower incisors.
dos cosas.
I want two things here.
Sin
One of them is
colisión
without
contra
collision
antagonistas.
against
Es decir,
their antagonists,
vamos a explicarlo además,
which means, and we'll try to explain it.
overjet
So generate an overjet
comience
and
a
immediately
inclinar
start to do the
incisivos
proclination
inferiores.
of the lower
Como
incisors.
es una clase 2-2, no quiero que me
Since
hagan
it's a class 2 subdivision 2, I don't want this that I'm showing to happen,
porque puede haber una cierta colisión.
because there could
Quiero
be
que hagan esto.
some level of collision. I want it to do this. I want it to be sequential. Upper proclination, lower proclination.
Así se solicita. Sin
So this is
colisión
how
con
I'm
sus antagonistas.
requesting it, without a collision with antagonists.
Alinear incisivos
Align
inferiores
lower incisors
sin colisión,
without collision,
es decir, sin fricción
without
entre
any
ellos.
friction
Yo no
between them.
quiero que
I don't want there to be a friction between the incisors.
vayan abriendo
I
un
want them
poco
to
los espacios.
open
De esa
in terms
manera
of
vamos a
spaces.
lograr siempre
This way we will always be
haya
able
una
to
correcta
get
adaptación.
correct adaptation.
Bien.
Very well.
Entonces,
Very, very well.
vamos a solicitar que,
And we will also request,
a ponerlo,
I like to add it here,
alinear
align,
frecuentemente
preferably
mediante
by means
expansión,
of expansion,
expansión, coordinando
coordinating with
antagonista
the antagonist arch,
y mediante
and
proclinación.
by means
Los
of
movimientos más
proclination.
previsibles con Invisalign.
These are the most predictable movements with Invisalign. This is what we are going to ask.
Prometido,
This is not a patient with any periodontal issues. I see periodontally
banda de encía
uh,
queratinizada para más,
good space here with keratin,
tampoco
and
veo, una tabla
I
cortical muy
don't
fina.
see
Por tanto, vamos a ver
uh,
cuánto
any cortical issues.
Siempre
So let's see how much we can incline, so we can always reduce. And a very important thing to do before sending this first change is to check the Bolton index. This is something I always do. So looking at the Bolton table, we say that we have an excessive of mandibular Bolton from tree to tree, 0.62. So this is what we could tell them. Add 0.6 millimeters of IPR, an inferior IPR, divided in 0.2 millimeters between 3.1 and 3.2, between 3.1 and 4.1, and between 4.1 and 4.2. 3 different points, 0.2. So we'll have a total of 0.6. And there's a 2 millimeter maxillar excess. I would wait to see this, the change that they will send us. I'd like to see, frankly, this Bolton index, this posterior Bolton index with a maxillar excess, that when they send me back with a molar class 1, probably we won't see any class 1 with the canines, but maybe class 2. If this is the case, we will request a slight IPR between the canine and molar to compensate the posterior Bolton. But I like to leave it for another moment. Well, let's send these cases to see what clean check we will get. And then we move to the next doctor.
Hello everyone, nice to meet you. My name is Kenji Ojima. So I'm very honored to share my experience to create my clean check. So please have a look. This is a initial one. This is I create for the new one. So what is a differentiation my part of the control for the teeth movement. Initially, I think this patient is a very severe class 2, division 2 situation. Have a look. This patient is mandible will be shift to the back. You can see here is a very shallow is lip here. Then I think this patient is a tough, very big for the fat around the neck area. Then I think this patient will be sleep apnea syndrome patient. And this patient is a severe deep bite also. Then we have to need correct initially upper anterior teeth this area, because my suggestion is this patient upper anterior teeth is lock or block to the mandible. Will be mandibular is shift to the more back. Then I think maybe this patient is a condyle position is a backward. Then anterior disc is going to the forward. Then something problem. This patient have a something problem is a condyle disease. Some of the time the TMD situation. So we have to think about not only teeth control, we have to think about is a more advanced around the joint, mandible, and the headache, and the neck ache, and the open and the close. That is very important thing. Then now only information is these photos, cephalometrics, and the clean check. Initially, I all the time checking the patient for like this, the muscle check, and the joint check, and the moving check, everything. Then integration, so that how do I do this patient clean check movement fast. Then my planning at this time, only this information. I have to create this anterior situation first, because this patient problem, the mainly is a deep bite and the class 2 division 2, and we have to correct anterior teeth is a proclination first, and we have to correct lower anterior severe curve. Okay, so we have to do initial time is a correct of the curve of SPI, and we have to do correct of the anterior teeth is a proclination. After that, I think the rescanning again, then so the check for the mandibular position, right position or not. Will be, I think, condyle position is maybe just advanced. Patient is a release for the mandible because of after proclination anterior teeth, is a mandible is a more advanced, relaxed position. Then take a scanning again, then create a clean check second. That is better way. But the initial time I send to you so that I create for this clean check. Please have a look why I should do this one. Okay, so that if you have an interesting, please check my YouTube channel. Our YouTube channel is you can see more similar my case. Thank you. Muchas gracias. Obrigado. Bye bye.
Well, what did you think? I thought all their comments were fantastic. Now, I have here some highlights and bullet points we can use to compare each of the outputs from the final stages of each treatment plan. When we look at these three different treatment plans, it's very clear to us that each of the three doctors followed an idea or a line of reasoning. For instance, the first doctor tried to optimize a treatment plan and give us all the movement right on the first clean check. On the other hand, Dr. Pedernera, on our second model here, divided up the treatment plan into two phases. So he focused first on one phase, and then he wanted to see how that turned out before making a decision for the second phase and how that would go. And in our third solution here, Dr. Kenji opted for a two-phase treatment plan where first he leveled out the curve of SPI. He was very clear, in a situation like this, you have some limitations in terms of the tools you can use, and an appropriate diagnostics. So he was very clear. He said, since I had this limitation, I opted for a two-phase treatment plan. So first he leveled out the curve of SPI, and then later he would work on the anterior-posterior sector. Looking at a vertical view of the treatment, we see that in order to correct a deep overbite, all three speakers opted for intrusion of upper and lower sectors both. So we can see that this intrusion was spread out, part of it on the upper and part on the lower teeth. Some speakers opted to add a little bit of IPR in order to gain some space during this intrusion. And again, still vertically, looking at these ClinChecks from a lateral view here, we see that some speakers opted for a little bit more proclination and others less, which is again normal in this situation where you're planning out a curve of SPI. And it really depends on how each doctor likes to work. And when you look at this case cross-sectionally, we see that all three speakers focused on more or less the same amount of expansion, both in the upper and lower arches. And this, I think, is a very interesting segue for us that to talk about something we've been mentioning over the past few days, and that's the G8. Dr. Guilherme mentioned some of the benefits and points of action of G8, and it's very easy for us to see G8 at work here. I wanted to put this in a full screen view for you so that it'd be easier for you to see. Looking at this movement table here and comparing the three treatment plans, we see that some upper teeth here in this region that had both intrusion and proclination, in the case of expansion, they're shaded in blue. And this means that we had a line smart force activation, and that's thanks to G8 in this case. And we can see this in both the upper and lower teeth's movement tables. Looking at this treatment from the sagittal point of view, we also see some differences. In the first treatment plan here, we see that the doctor, right from step 1, he starts using ancillary mechanics. So, sequential distalization using rubber bands. And it's interesting here that there's both button cuts and rubber band cuts. And the doctor mentions that the button cut itself will help extrusion of the lower molar. In the second treatment plan, the doctor opts first for sequential distalization without ancillary mechanics, and then after looking at the second ClinCheck, he would decide whether to add some IPR between molars and canines, or maybe he would have the choice to add a little bit more distalization to reduce the amount of IPR. And in the third treatment plan, Dr. Kenji left this part of the treatment, the sagittal issue, to a second step of the treatment. And when we compare the initial and final stages of each treatment plan, we see very similar results. I think the major difference here has more to do with customization and personalization of each treatment plan and using more or fewer aligners. And the results in all three cases are very well conducted, thanks to this excellent tool we have at our disposal. And so I would like to thank once again for participating in this activity with us, Drs. Guilherme Thiesen, Martim Pedernera, and Kenji Ojima. Thank you very much.
That's great, Almir. Different plans and different professionals with completely different backgrounds, and they all reach the same result with the support from the Align technology. Fantastic.
That's right, Renata. And that's why we always say that as well as orthodontists' technical expertise, our solutions help reach the best result. That's what was shown here with help from our doctors.
Well, Almir, now we have reached one of the most anticipated moments in our agenda, the Align Forum Latin Awards from 2021. Is that right?
That's right, Renata. I'm just thinking, if we're excited here, can you imagine the finalists? All of you had the chance to vote yesterday on the 3 categories: Invisalign for adults, for teens, and restorative dentistry. And this year we have expanded the categories to include restorative dentistry.
That's right. We did it, so all doctors who use Align digital technologies could submit their cases. We will now announce the winners.
That's right, Livia. But before we tell you who won, let's take another look at the finalists for each category. Take a look. So, how are you feeling on the other side of the screen? Are you excited? So now we are reaching the great moment for this event, the award for the best cases that were voted for the Align Forum Latin Award.
Almir, just hearing the song gives me thrills because I know this is what we've been waiting for. If we feel this way, I can only imagine those at home waiting to learn who won the Align Forum Latam 2021 awards.
Let's get started. Good luck to every one of our finalists, and let's see the results. In the category Invisalign for Adults, the winner is Dr. Jaime Montoya from Colombia.
Congratulations, Dr. Jaime.
In the category Invisalign for Teens, the winner is Dr. Cynthia Veit from Brazil.
Congratulations, Dr. Cynthia. I want to congratulate all doctors who have been awarded. Now, I'm happy to announce the winner in the category Eye Terror Restorative Cases. The winner is Dr. João Renan de Almeida from Brazil.
Congratulations, Dr. João Renan. Congratulations to all our winners, and thank you to everyone who participated. It really is a huge honor to be able to count every single one of you as our partners and guests. And so if you entered, but your case was not one of the winner, please try again next year at Align Forum LATAM Awards 2022. See you there.
Thank you, and we'll see you in 2022.
What an amazing edition for this Align Forum Latam. Livia and Almir, congratulations. The whole team from Align. Congratulations to all of you.
Thanks, Renata. Don't forget, folks, that this is just the beginning. We still have more events together in 2021, and we're already planning the next edition of Align Forum LATAM in 2022, with attention to every detail, to make it even better than this year's edition. Our efforts and knowledge will only grow, so that increasingly more professionals can have access to specialists, cases, and Align's digital dentistry solutions.
It is always a huge honor being able to bring such amazing experts together to talk about how to use Invisalign, iTero, ClinCheck, and Exocad in real cases. As Almir well said, our purpose is to walk side by side with our colleagues and partners to further our knowledge. This is what motivates the clinical education team. We look forward to seeing you again. Thank you, doctors, and I'll see you next time.
And once again, I would like to thank you all for being here, and especially Dr. Livia and Dr. Almir for having shared this stage with me during the 2 incredible days we had together. It has been an honor to be with you. Thank you all for watching, and see you at Align Forum Latam 2022.